to take the stage as chair of the first plenary session of the Centenary academic sessions of the Sri Lanka Medical Council. Please join me in welcoming her with a round of applause.
Thank you, and very good morning to all of you. I am honored to chair the first plenary session for today, titled A Century of Excellence, reflecting on Sri Lanka Medical Council's legacy and achievements. We have three very distinguished speakers lined up to address you all. Each speaker is allocated 15 minutes, and I very kindly request all the speakers to adhere to the time scale. It is my pleasure to introduce the first speaker, Vidyajyothi Professor Wajira H.W. Disanayake. He is the current president of the Sri Lanka Medical Council, Dean of the Faculty of Medicine, University of Colombo, and Chair and Senior Professor of Anatomy, Genetics and Biomedical Informatics of Faculty of Medicine, University of Colombo, Sri Lanka. He is a past president of the Sri Lanka Medical Association and past president of the Commonwealth Medical Association. Also the immediate past chairperson of the Commonwealth Health Professions and Partners Alliance and immediate past registrar of the Ceylon Medical College Council. I now kindly invite Professor Wajira Disanayake to come up on stage, and he would be the best person to speak on 100 years of regulating healthcare in Sri Lanka, key milestones, challenges, and success stories. Over to you, Prof. Wajira.
Thank you very much. Good morning, ladies and gentlemen. It gives me great pleasure to welcome all of you to the centenary celebrations of the Sri Lanka Medical Council. We are here this morning because in 1924, the government, the colonial government at that time, enacted a medical ordinance that gave rise to the establishment of the Ceylon Medical Council. On 25th June 1925, the council met for the first time, and today, last week, on 29th of June, we had our centenary council meeting. So what a wonderful achievement. Century, and may I say, a century and not out, because I don't think there is any other regulatory agency, maybe barring GMC and a few others, that have stood that test of time. And we are now, as was said, looking for another century toward the future. Let me go back to when medical education was established in this country. In 1848, not in Colombo, but in Jaffna, in Manipai, where the Green Medical School was established by the American missionaries. The medical school lasted there for 25 years, but in 1870, the government at that time came in and established the Colombo Medical School, or the Ceylon Medical School, of which I'm the dean at the current moment. I'm privy to all the documentation from that time because they have been nicely preserved and archived in my office. And I saw recently that the students, when they were winding up Manipai Medical School, were absorbed into the Colombo Medical School in 1885. So something to reminisce about, because it parallels some of the developments that we have had recently in the context of some of our private medical education, as it were. In 1870, the diploma of LMS was being given to our graduates from the Colombo Medical School. And in 1880, it became registrable with the GMC without further examination. However, registration of doctors did not take place until 1905, when the Medical Registration Act came into being. And for the first time, organization set up within the Ceylon Medical College, the Ceylon Medical College Council, started registering the medical practitioners. However, there was calls for the regulator to be independent of the council. I saw in the editorial of the Journal of the Ceylon branch of the British Medical Association, that is what the Sri Lanka Medical Association was known at that time, an editorial which welcomed the legislation establishing an independent regulator and wishing it all the very best. That was to say that there was pressure from the profession to bring in regulation, independent regulator. Of course, that led to formation of the Ceylon Medical Council. 1927 saw the establishment of enactment of a new act which gave further strengthened the council, and the council was fully on the way as it was. Thereafter, further developments took place. Medical education, we had the University of Ceylon being set up, the MBBS degree being given, these became registrable, and as time went by, post-colonial times, going into the new era of a different global order after the Second World War, the opening up of various other countries, Sri Lanka becoming a non-aligned state, and so on, and more access and diplomatic relations being made with other countries, the concept of temporary registration came into the picture in 1946 and in 1961. And thereafter, more formal pre-registration requirements in the form of an internship was established in 1955. For the first time in 1965, we saw the commencement of the Act 16 examination for foreign medical graduates. And that today, as you know, has expanded onto being a ERPM examination. And with foreign medical education access becoming ubiquitous, more and more doctors or young students choosing that path, we are now working on making the ERPM a properly standardized licentiating examination modeled according to the GMC's PLAB and AMC's examinations. And the first cohort that is sitting that exam will be starting next Monday. We look forward to the support of the entire medical community to make the standardized licensing exam, the new format ERPM, a success, because that is the way forward if we are to make sure that our exams are world standard and on par with the rest of the world. Further changes took place in the 1980s. The concept of renewal of registration, need for revalidation, and so on came into the picture. However, although renewal was enacted, we couldn't get revalidation into the picture for various reasons. However, I'm very pleased to know that during the past 2 years, as you all know, we have renewed registration of all practitioners, and going forward, when 2030 comes, we are now getting ready to introduce revalidation, and that is another step forward in our forward journey, where we need the support of all our practitioners, and I've heard the commitment from all strata of our practitioner community on their support for those innovations. The final bit of change to our ordinance came in 2018 when we enacted the regulation to start a specialist register, and now the specialist register is fully established and formed. The developments in the dental field also mirrored that of the medical field. The dental community was always with the medical community, and we went forward together. First, the dental practitioners were registered in 1915, and then everything else followed and mirrored the medical profession. When we look at the other categories of professionals, the apothecaries or the estate dispensers and the estate dispensers was the first one to have a register after the medical doctors. That, I guess, showed the priority of the government at that time, which opened up the estate sector and the proliferation of estates all over the country. And the importance the colonial government placed to that sector is highlighted there. When I move over to the other fields, the allied health fields of today, the first category of allied health professionals to be on a register were the midwives. You all know that Sri Lanka's healthcare sector, the foundation, the pillar, the central pillar, was the maternal and child health services that we established around that time in the 1920s and 30s, on which we have built up everything else. So that shows the importance those services were placed at that time and how well that regulation has helped us to move forward as a country and to get our country to a status where it is the envy of the world. I can remember being at the Commonwealth Health Ministers meeting in 2018 when Grace Michel, the wife of Nelson Mandela, gave the keynote speech, where in her speech, she said 5 times, why can't the rest of the developing world be like Sri Lanka? And sitting there in the audience, I was amazed that our health services were held in such high esteem across the world. We know we have the developed world look up to us, but I think that was an endorsement of how the developing world look at us as well. Then, of course, we had other categories. The nurses coming in 1949, but today nurses are a different community, a different regulator altogether, and they are the only medical or health professional group within our sphere who is outside of the Sri Lanka Medical Council. Pharmacist register was established in 1927, and they have been with us ever since. In 1980s, when the health sector expanded, we had paramedical assistants, the concept of the paramedical assistants coming in, and 12 categories of allied health professionals were included into the register. I'm not going to read them out in the interest of time. And in 1998, 4 of those categories were elevated to the level of what was called professions supplementary to medicine. And all of them are now regulated by us. Let me dwell briefly on the challenges of medical education. We had, as you know, various attempts of expanding medical education, both through the state sector and the private sector. And that posed various challenges to us. And the expansion of the foreign medical education sector also posed challenges to us. However, to overcome such challenges, now we have the mechanism, the legislator, the tools in place. In 2020, the minimum standards for medical education were promulgated by the Parliament. In 2021, we established an independent accreditation unit in the SLMC. And in 2023, we received the coveted WFME recognition. Only the 3rd country in Asia to have a WFME accreditation unit at that time. Now we are in place to regulate effectively, regulate independently. And the threats to those really come from within. So I would urge the entire medical community to join hands with us, the SLMC and its accreditation unit, to ensure that our accreditation mechanisms are not compromised, they are intact, and they are taken forward. And I'm very pleased that all the deans, all the medical educationalists in our country, and the entire medical education and the allied health education community are with us in that endeavor. Finally, let me move on to the world that we live in. a world of personalized medicine, genomics, digital technologies, AI, social media, and of course, cross-border healthcare. These pose various challenges, unprecedented challenges that we would not have been ready in the past. In the discussions or presentations that happen today, you will see the innovations that are coming in to tackle with these. In the evening, we will be launching our Centenary volume, and we will showcase in that volume, we have showcased in that volume too, how we have brought about structural changes within the council to address those issues. So I call upon the entire medical, dental, and the health professions community to join hands with the SLMC to bring about these changes that we so desire so that we are fit for purpose in the next 100 years. To do this, we need new legislation, and I'm pleased that under the leadership of Professor Janaka De Silva, in the past 3 years, we were able to draft a new medical act, and that is now before the Ministry of Health, and I hope that we, in this year, will be able to enact that legislation so that we have the legislative power to do what we want to do. And in that sense, we are now looking for the future with confidence. So with those words, ladies and gentlemen, let me wind up. But because I'm the first speaker today, I think I will be failing in my duty if I do not thank a few individuals. Dr. Sunil Vijayasinghe. Last year, he planted a little acorn, the thought of a centenary celebration. And Sunil, I'm sure you will be very happy that it has grown into a mighty oak. So Dr. Sunil Vijayasinghe deserves that acknowledgement for his thought that has planted this. Professor Ranil Fernando, he took the mantle from there and ran it beautifully with the support of everyone, all the council members, the staff of the council, and others, many others. Thank you very much, Prof. Ranil, for your leadership. Of course, behind the scene, giving all that support was Dr. Hemantha Herath, the registrar, with his legacy of administration in the Ministry of Health. He came into the council at the correct time, and Hemantha gave all the admin and financial support to this endeavor. Hemantha, thank you very much for all your work. And all this is captured in our Centenary volume, which will be launched this evening at our Centenary celebration. And I'd like to thank Professor Manori Gamage for editing the volume and taking the leadership with the volume. And last but not least, let me also thank our special invitees who are here, the chair of the GMC, the chair of the IMRA, and I know there are delegates from the WHO conference that was held in the past 2 days, medical regulators from the Sierra region who are here today, and I'd like to thank Dr. Palita Bekon and his team at the WHO for making that happen, and I'm pleased that all of you are here today as well. And finally, ladies and gentlemen, without your presence, these celebrations wouldn't have been a success, and I'd like to thank all of you for being here and being a part of our journey, our shared journey, which is also your journey, and we look forward to engaging you in the years to come. Thank you very much.
Thank you very much, Prof. Wajira, for taking us through the history, development, and the role played by the Sri Lanka Medical Council as the main regulator of healthcare in Sri Lanka for past 100 years. I now kindly request Professor Wajira to be on stage. And our second speaker in this plenary session is Dr. Anil Jasinghe. He needs no introduction to this audience, but for formality's sake, he is the present Secretary of the Ministry of Health and Mass Media. And prior to his current appointment, he served as the Senior Additional Secretary at the Presidential Secretariat and CEO of Sri Lanka Climate Change Office. He is a former Director General of Health Services, and during this period, he had demonstrated remarkable leadership in 2004 tsunami, trauma care management in final stages of civil war, and the COVID-19 pandemic. May I now kindly invite Dr. Anil Jasinghe to come up on stage and present on the role of regulation in the Sri Lankan health care system, a medical administrator's perspective. Over to you, Dr. Jasinghe.
Thank you. In this morning, I'm truly happy to be here with you on this 100-year celebration of Sri Lanka Medical Council, which is a momentous occasion not only for medical fraternity and the allied health professionals, but also for the public of this country. So, going back to the history, the global pioneer example of medical accountability was marked with inception of the General Medical Council of the United Kingdom in 1958. Locally, a century back, the Ceylon Medical Council was formed in 1924, which evolved in 1972 to become Sri Lanka Medical Council. Time to time, amendments were brought in to the medical ordinance in keeping with the developments of the healthcare services. The Ministry of Health is the largest employer of regulated medical professionals in this country. Within our ranks, we have a significant number of medical officers, specialists, and allied health professionals. Notably, 50% of outpatients and 90% of inpatients receive care in healthcare institutions operated by the Ministry of Health. It is important to recognize that in absence of a regulatory body, our capacity to serve the population would have diminished significantly. I would like to draw your attention to the critical importance of maintaining the quality of care provided by medical professionals. Achieving this goal involves several key components. First and foremost, it is essential to provide high quality, standardized training and educational resources for undergrads. The ministry is committed to upholding the standards set by the Sri Lanka Medical Council in the establishment of new medical faculties. We must carefully consider unregulated proliferation of medical faculties in the country, ensuring that we prioritize quality and adherence to established standards in our approach. The ministry has consistently aligned with SLMC's objectives, continuing medical education, human resource planning, health workforce quality in context of universal health coverage. This reflects the national need, not just academic benchmarks. On the other hand, for us to assure good quality of care, we need to have a healthcare ecosystem which is modern, manageable, and covers the entire spectrum of care. Historically, there has been significant political and social pressure to develop and upgrade various healthcare institutions. In the past, this led to an unsustainable expansion of health services, which ultimately compromises quality. I am pleased to report that the current administration has made a decisive move to hold this unsustainable growth. Instead, we are focusing on enhancing quality of care within our existing capacity, ensuring that expansions are made where they are truly necessary. The SLMC is committed to maintaining high standards of care and protecting public health. This encompasses various facets of healthcare practices, including registration and licensing, medical education, and professional conduct of professionals. Quality assurance is a fundamental responsibility of a regulatory body, which involves overseeing the quality of care delivered by licensed professionals. Furthermore, the SLMC must proactively monitor the standards of individual healthcare professionals across all aspects of outlined in this provision, extending beyond mere entry criteria, and the regulatory body is tasked with investigating complaints against healthcare professionals and taking appropriate action when necessary. One of the primary objectives of a regulatory body is to safeguard the rights of healthcare professionals, equally protecting the interests of care seekers. This dual responsibility is essential for maintaining trust and integrity within the healthcare system. Regulatory provisions for specialists are typically outlined in medical ordinances world over, which establish a framework for accountability and quality assurance. Ultimately, the regulatory body is tasked with ensuring that both healthcare providers and the patients receive the support and protection they need to thrive in a dynamic medical landscape. In summary, regulatory bodies play a crucial role in safeguarding public health and safety by ensuring that healthcare professionals are not only competent but also adhere to ethical standards. Ultimately, these organizations are essential for maintaining public trust in the healthcare system by ensuring that professionals are adequately qualified, well-trained, and held accountable for their actions. Continuing medical education plays a vital role in ensuring high-quality medical care. As administrators, we bear the responsibility of maintaining the necessary facilities and resources to support CME initiatives. To promote ongoing education and professional development, healthcare administration must provide a range of incentives and facilities. These may include performance-based compensation, enhanced monetary benefits, access to training programs, and flexible working arrangements. A regulatory body must play a crucial role in overseeing these initiatives, ensuring that they are effectively implemented. However, several challenges can hinder optimal execution, including financial constraints, overly centralized nature of government medical professionals, and limited fiscal space in the government machinery. It may be worthwhile to have the CME program is always in the best interest of the professionals and recipients. Needless to say that modern progressive regulations ultimately will protect the good professionals while protecting the interests of healthcare seekers. The ministry can facilitate to ensure that there is a coordination with the regulatory authority to safeguard patient safety and quality. We have the institution called Healthcare Quality and Safety Secretariat, which just a few months ago upgraded to a bureau, and now we are to embark on accreditation of certain healthcare institutions. In this, we will be working with leading accreditation agencies in the world. As we look forward, we should focus on how to overcome challenges, minimize limitations, and maintain equitable delivery. Firstly, we need to continue modernizing regulations, which I think the President spelled out that you have started on. The health landscape is evolving rapidly. New technologies, digital health records, telemedicine, and artificial intelligence, and moreover, the advancing perception of care seekers. If it is necessary that the composition of the regulatory body is also made rational. Secondly, we must focus on streamlining the licensing process, not to compromise on quality, but to ensure that good qualified professions are not lost in bureaucracy. Thirdly, greater transparency and accountability. The public must know they can trust the process, that complaints will be heard, and justice will be fair. Finally, when we analyze the functions of Ministry of Health and SLMC, we have a shared responsibility. The administration and regulatory body can and should enrich each other's functions, work in more close coordination and collaboration so that the country will receive unmeasurable benefits of such collaboration. Public expectations are also changing rapidly with increasing demands of services, and look for transparency, accountability, equitable access to care, which will influence every policy decision. The administrators of the Ministry of Health plays a pivotal role in deciding, revising, formulating policies for the benefit of people through health system improvement, regulations, and guidelines to ensure health and safety of the population. We must recognize that regulatory bodies enjoy powers that are otherwise enjoyed by the executive. This is particularly important as we engage with a community of highly qualified professionals who are not only organized but also capable of significant self-governance. Therefore, as we exercise the authority entrusted with us, we must proceed with caution, ensuring that our services are delivered fairly and judiciously. It is imperative that we effectively address the needs of aspirations of society while upholding the highest standards of professionalism and integrity. Let this 100-year celebration be both a tribute to the past and a call for action for continued collaboration, innovation, and unwavering dedication to building a healthier Sri Lanka for generations to come. Let us unite in our efforts, fueled by a shared belief, a healthy population begins with trusted regulation. By safeguarding standards and nurturing transparency, we ensure that Sri Lanka's healthcare remains excellent, equitable, and resilient for the next century and beyond. Thank you.
Thank you very much, sir, for highlighting how Sri Lanka's healthcare system could be sustained and improved to ensure a fair, safe, and resilient system for all Sri Lankans through regulation. I kindly, is already seated. Our final speaker in this plenary session has traveled all the way from New Zealand to be with us today. And she is Madam Joanne Simeon, Chair, International Association of Medical Regulatory Authorities, IMRA, and she is also the Chief Executive of the Medical Council of the New Zealand and have experience working in medical regulation for more than 20 years. I kindly invite Madam Joanne Simeon to come up on stage and speak on global perspectives on medical governance in the last century. Over to you.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ayubowan. Greetings from Aotearoa, New Zealand. Now, I don't have slides with me this morning, but if I did, I'd be showing a slide of the world map. And the reason I'd be showing a slide of the world map is because to remind us all where New Zealand sits on that map. There's been so many examples over recent years where New Zealand's actually been left off maps, including a recent example at the United Nations. Good morning, distinguished guests, colleagues and friends. Thank you for the invitation to visit your beautiful country and to speak to you here today on a global perspective in medical regulation. It's a privilege to be part of a panel of such distinguished guests while we recognise together the significant milestone and celebrate the centenary of Sri Lanka Medical Council. On behalf of the International Association of Medical Regulatory Authorities, or IAMRA for short, and on behalf of the Medical Council of New Zealand, I congratulate you on your achievement and your tremendous service. Over the past century, medical regulation has undergone profound transformation from insular systems of professional self-regulation dominated by the medical profession with little public or governmental oversight. We've moved to collaborative, transparent and public accountable models. The journey of medical regulation in so many ways is a reflection of our society's evolving expectations of medicine itself. In the early 20th century, medical regulation was largely self-regulated. The medical profession itself, that is doctors, regulated doctors. The underlying premise was one of professional trust. Trust that the profession could and would govern itself with integrity. This model worked for a time, but it was not without its limitations. Transparency was often lacking. The public had little insight into the processes of registration, complaints, or disciplinary action, and no understanding of decision-making of regulators. Most critically, professional regulation left out the voices of those most affected by healthcare decisions, the public and patients, the very communities we are here to serve. From the latter half of the 20th century and accelerating into the 21st century, a paradigm shift occurred. Regulatory bodies around the world began to recognise that public confidence could not be sustained by internal accountability alone. Today, we recognise that I'm sorry about the crackling, is that me that's doing that? Today we recognise that good regulation embeds public and consumer input at every level, governance and operations, including decision-making, setting of standards, accreditation of training institutions, and investigation of complaints. Public and community members provide essential input at governance level, sitting on regulatory boards. Diverse public and patient perspectives shape the professional standards we set for the profession. We seek community input into our decision-making. We are transparent. Regulatory decisions are published, reasoned, and open to scrutiny. This change reflects a broader truth. The legitimacy of regulation depends not only on technical rigour, but also on social accountability. Trust is the foundation of both medical professionalism and effective regulation. But trust is not static. It must be earned and maintained. To be trusted, we must be trustworthy, and we must demonstrate trustworthiness. For regulators, trust comes from demonstrating consistency, fairness, responsiveness, and transparency. It is reinforced by processes that are open to challenge, responsive to criticism, and grounded in evidence. Public trust in the medical profession is high, and the profession must demonstrate a high level of ethical conduct and clinical competence and a visible commitment to patient care to maintain that trust. Regulators have a role in reinforcing this trust, not by distancing ourselves from the professions we regulate, but by engaging with the professions and supporting high standards of medical care in the interests of the public. Trust in regulators and trust in the profession are interlinked. When regulators act in the public interest, they support the standing of the medical profession. We understand that the public must trust the medical profession, and we also need the public to trust us as the regulator. However, the third component of trust is that the professions we regulate must trust us as regulators. They must trust that we will be proportionate, fair, and transparent in our decision making, and that we do so with integrity, a compassionate approach, and with the safety of the public uttermost in our minds. Now, we all know that the purpose of health practitioner regulation has always been to serve and protect the public, and this includes promoting patient safety. However, regulation has advanced and cannot sit in a silo. Professional regulation must be linked to the advancement of wider health system goals, and we've heard a little bit about that this morning. Regulators, we all have a key leadership role in the wider health system. In recent years, particularly post-COVID-19, we've seen a growing interest from governments in professional regulation, and this is not surprising. Health systems face immense challenges: workforce shortages, inequities, the impact of digital health, and the demands of ageing populations. The World Health Organization, and I think the person who is responsible for this guidance is here somewhere in the audience, but I can't spot her. The World Health Organization recently published a guidance on health practitioner regulation. This guidance describes key policy considerations in the design, reform, and implementation of health practitioner regulation. I feel like I'm electric at the moment. It reinforces the notion that regulators are not only charged with ensuring professional standards, but also as contributors to workforce planning, system reform, and quality improvement. This creates great opportunities for regulators, but also tensions for us. While we must engage with the wider health system, and we do have an important role to play in engaging constructively with health system priorities, regulators must remain independent from political agendas. We must be responsive and proactive while protecting core principles, fairness, integrity, and public interest. Regulators of health professions across the globe now play critical roles in shaping scopes of practice, recognising new practitioner roles, and responding to global workforce challenges. Many of us are now regulators of more than one health profession. We have demonstrated great flexibility and agility in emergencies. Regulators of health professions responded rapidly to adapt to the COVID-19 pandemic, introducing regulatory flexibility. Many of us changed policies, allowing surge workforce to be put in place quickly and permissive telehealth services to take place. We engaged across health systems and provided much needed guidance to health professions during a time of need. Our proactive approach regulatory flexibility and responsiveness took place without compromising patient safety. In fact, The primary result was enhanced public safety. We need to carefully reflect on lessons learnt during the pandemic emergency and consider how we can apply those lessons and agility in our ongoing regulatory work. We do have a key role to lead and influence. However, our leadership and systematic influence must be exercised with care, humility, and consultation and engagement widely. Our health system is more complex than ever. Changes in models of care, changes in the way consumers access care, and emerging technologies create new challenges for accountability, transparency, equity, and patient safety, resulting in new challenges for regulation of health professionals and a greater need than ever in collaboration across the system and across jurisdictional boundaries. The global nature of health regulation is increasingly clear. Practitioners move across borders. Patients access care in virtual settings. Standards in one jurisdiction can influence expectations elsewhere. We are all facing challenges that traverse jurisdictional boundaries and that are global in nature. However, we recognise that there is a diversity of contexts, population health needs, health systems, health practitioners, and economics across countries. Therefore, the policy considerations must be adapted to the local needs and objectives that are specific to that particular health system. The International Association of Medical Regulatory Authorities, IMRA, and its members have a unique role to play in this global ecosystem by sharing data, sharing insights and approaches that strengthen public protection everywhere. We must support one another in upholding professional standards while safeguarding public trust. IMRA supports and facilitates collaboration on emerging issues and research, and all of the communities we serve benefit. Crucially, we must also reflect on what the last 100 years have taught us. That regulation is most effective when it is co-created, with valued input from patients, health professionals, policymakers, and engagement with the government and the wider community. In closing, medical regulation evolved from a closed, self-governing model to a dynamic, inclusive, and globally relevant institution. The public rightly expects not only competence from health professionals, but also accountability, compassion, and integrity. Regulators, in turn, must model those same values and must also demonstrate transparency, agility, and proportionality. Let us go forward with clarity of purpose, humility in our leadership, and steadfast commitment to the communities we serve while we strive to achieve our primary purpose of ensuring public safety. Tēnā koutou, tēnā koutou, tēnā koutou katoa.
Thank you very much, Madam Joint. And thank you very much for taking us through the medical regulation that has transformed from a system of professional self-regulation to one that is increasingly inclusive, transparent, and of public accountability. We are very grateful for you for traveling long miles and to be with us today and sharing your vast experience on medical regulation. We have reached the end of a very successful first plenary session, and I should thank for all the speakers to keeping up to the time. And this session has been very informative. Let us all thank the excellent three speakers with the our usual way of appreciation. Thank you.
Thank you, Madam. And now the session chair will present tokens of appreciation to our eminent speakers in recognition of their invaluable contributions to this event. And I have the honor of inviting the speakers of the first session to please come forward and accept this token of gratitude. Professor Vajira H.W. Dissanayake. Dr. Anil Jasinghe. And Ms. Joanne Simeon. And I now have the honor of inviting Professor H. Janaka De Silva, Council Member of the Sri Lanka Medical Council, to present a memento to the session chair as a gesture of appreciation for graciously presiding over this session. Thank you to our distinguished dignitaries for your presence and participation. You may now kindly take your seats as we proceed with the next item on the program. And before we commence the next session, I would like to inform you all that refreshments will be served from 10 a.m. to 11 a.m. at the Lavender Hall, and you're cordially invited to help yourselves at your convenience. And please do return to the session quietly, as the proceedings will continue without pause. And now we move on to the second plenary session, titled Ensuring Quality and Safety in Healthcare Delivery. And it is my distinct honor to welcome to the stage Dr. Ananda Vijaywikrama, Council Member of the Sri Lanka Medical Council, who was a senior consultant physician at the National Institute of Infectious Diseases, Sri Lanka, the chairman of the National Medicines Regulatory Authority, and a senior lecturer in medicine of the Faculty of Medicine, University of Moratuwa. He has played a pivotal role in the development of guidelines, patient education, and the treatment of COVID-19 patients in the country. It is now my privilege to invite Dr. Ananda Vijaywikrama to assume his role as chair of the second plenary session. Please join me in extending a warm and sincere welcome.
Good morning, and thank you very much. I welcome you all for the plenary session of this centenary celebration. May I take this, now may I invite the resource persons for the plenary, Professor Priyadarshini Galapatti, Dr. Pali Tabekon, and Justice Honorable Jasanta Kodagoda. Professor Priyadarshini Galapatti is Senior Professor of Pharmacology of University of Colombo, and also she is a member of the Board of National Medicines Regulatory Authority. She has been a consultant to the WHO on patient safety for the year 2023 and 2024, and of course I have the pleasure of saying that she's a batchmate of mine, and she had been working closely on not only on pharmacology and patient safety issues as well for Sri Lanka and also for the WHO. Dr. Palita Bekon, I don't think he needs any introduction to the audience. He's a very senior academic who had been a consultant to the WHO and also had been the country representative of India, WHO representative to India, and working very closely on many health issues in Sri Lanka, including medicines regulation, patient safety, health policy, and also we are privileged to have you, sir, for this plenary session. And Honorable Justice Yasantha Kodagodis, again, does not need any introduction. He had been serving in the Attorney General's Department for many years and then was appointed as an appeal court judge and then Supreme Court judge. And we all know his interest in, especially in relation to medical ethics and education. And we are privileged, and thank you very much for accepting our invitation and coming for this session. Thank you. So the first presentation will be by Professor Priyadarshini Galapatti.
Good morning to all of you. First of all, let me thank the Sri Lanka Medical Council, Professor Wajira Disanayake President, for inviting me to deliver this presentation. On a key topic, patient safety is at the heart of any medical regulator. So I will be talking to you on patient safety and quality assurance towards a culture of zero harm. This is my overview. I would be talking about the global burden of patient harm, as we have learned from this first ever global patient safety report published by the WHO last year, and the global action to prevent patient harm and improve quality of care, focusing on this WHO Global Patient Safety Action Plan, and then the role of medical councils and regulatory bodies with specific focus on Sri Lanka. The principle of first do no harm, primum non nocere, is a cornerstone of medical practice attributed to Hippocrates, which many medical officers take at the commencement of their medical practice. However, we know that despite global efforts, many patients are harmed and much of it is preventable. And most evidence on medical errors are coming from developed countries. However, now there is data to show that much more harm occurs in low and middle income countries. The modern patient safety movement started somewhere in the latter part of 1999 with this seminal publication from the US titled "To Err is Human," which highlighted the significant number of patient harm that occurs in the United States, and followed by many publications highlighting the high number of errors happening globally. And the modern patient safety initiatives now mostly focus on systemic factors within the healthcare organizations that contribute to patient harm rather than focusing on individual activities contributing to medical errors. I would like to pose a question to you, whether you know about the degree of patient harm as opposed to other high-risk industries. According to the WHO estimates, the estimated risk of death while air travel is 1 in a million. We had, recently we were focusing on the risk of air travel with the tragedy that happened in India. However, the estimated risk of death due to medical errors in healthcare is a staggering 1 in 300. So, although we wish people when they are going overseas, have a safe journey, have a safe flight, what we should be telling actually, when people seek healthcare, have a safe stay in healthcare, because you are more likely to die, not due to your illness, but due to an error that occurs in healthcare. So this is the significant harm that we are talking about and we are trying to reduce. So the global burden of patient harm was highlighted in this Global Patient Safety Report, the first ever such report published by the World Health Organization last year. And I was actually privileged to be a part of this core team from the WHO headquarters which published this report. And we found that one in every 10 patients are harmed in healthcare. And in low and middle income countries, actually 4 in 100 people die from unsafe care. And there are more than 3 million deaths that occur globally. And the important thing to note is that about 50% of this harm is preventable. For the patient safety globally, the 72nd World Health Assembly was a watershed moment because that's the year that the World Health Assembly adopted the global action on patient safety and recognizing patient safety as a global health priority and established an annual World Patient Safety Day on 17 September, and Sri Lanka has been celebrating this every year since that time. And WHO formulated a global patient safety action plan for the next 10 years going up to 2030, which is now being implemented globally. This Global Patient Safety Action Plan formulated a framework for action, which is called the 7x5 matrix, as shown here. And there I have highlighted some key activities which are relevant to medical councils. Policies to eliminate avoidable harm, such as protective legislation, having safety standards, regulation and accreditation, and particularly focusing on health worker education, skills and safety, which is one of the core functions of regulatory bodies, is highlighted in point 5.1, patient safety in professional education and training, and patient safety competencies as a regulatory requirement, which is ensured by the Sri Lanka Medical Council, and linking patient safety with appraisal system of healthcare workers, and finally, synergy and partnership and solidarity with stakeholder engagement, which is done in this kind of a meeting. So I would like to now highlight some common categories of patient harm. Medication errors. I am not highlighting medication errors because I am a pharmacologist, but because the data has shown that globally, the most common patient harm, which is accounting for nearly 50% of preventable patient harm, are attributed to medicines and therapeutic interventions. Because you know that rather than any other intervention, medicines are the most common intervention that healthcare professionals give to patients. So they are subjected to harm. And over half, 53% of this harm arises globally at the prescribing stage. And in low and middle income countries, 78% of this harm occurs in the prescribing stage. So, and often contributed by the prescriptions which are not very legible. And this is why we have proposed to the Sri Lanka Medical Council, going along with the global trends, to introduce a prescribing safety assessment in order to address this matter in Sri Lanka. Surgical and procedural harms is a significant burden, with over 300 billion surgical procedures performed every year, and 10% of preventable harm occurs because of surgeries. And healthcare-associated infections account for another significant burden, and things like catheter-associated bloodstream infections, catheter-associated urinary tract infections, ventilator-associated pneumonia, and so on. And 1/4 of these results in sepsis, antimicrobial resistance, and even leading to death. And all these things, these three categories, medication-related harm, surgical-related harm, and healthcare-associated infections, have been focused in WHO Global Patient Safety Challenges. These three have been identified as 3 global challenges and initiated activities on those. Another, in fact, until recently unrecognized one as the other 3 are diagnostic errors, where it has been now identified that about 5 to 20% of physician-patient interactions lead to diagnostic errors. And in fact, most people will suffer at least one diagnostic error in their lifetime, according to publications. And therefore, you might, your disease might progress, like, for example, cancer, if it is delayed or not diagnosed in time. In addition, there are many other common categories of patient harm that we have highlighted in this global patient safety report, like even patient misidentification still happens even in developed healthcare settings, pressure ulcers, and maternal and newborn care. And so these are the other ones which are highlighted and the WHO is focusing on in addressing in healthcare settings. So patient safety incident types can be near misses, if it does not reach a patient, but it can be a harmful incident or a non-harmful incident, depending on whether the patient, if it reaches the patient, depending on the harm that occurred. So how do we identify these errors which happen in healthcare settings? It is through incident reporting and learning systems, which is a process of documenting adverse events, near misses, and unsafe conditions, and it is a process which supports learning for improvement. However, unfortunately, we all know that there is very poor reporting in low and middle income countries, including Sri Lanka, which actually hinders learning from those instances and taking actions to prevention. And in fact, James Reason in 2000 published in the BMJ saying that that an incident reporting system is not about assigning blame for people, but it is about promoting a culture of safety. So, and with this reporting, we talk about building a just culture. So what is a just culture? It is an organizational culture which promotes accountability and learning rather than blaming people when things go wrong. And it is a culture in which individuals feel actually that they will receive fair treatment in the event of an adverse event. And there is, however, a clear distinction between human error, at-risk behavior, and reckless behavior. So in a just culture, the way how you respond to different, these types of 3 different behaviors are different. For example, human error, which is like, for example, if you select a wrong medicine, which is now we refer to as look-alike medicine. Now, that is actually is not a real error. It is where the system also has a responsibility towards that. So the response from the organization should be console and support and system improvement. In fact, in Sri Lanka, we did not have a list of look-alike, sound-alike medicines and how to identify them and to take preventive actions in separating storage, labeling, and so on. So through the Healthcare Quality and Safety Unit, we have actually developed a list of look-alike, sound-alike medicines, and Dr. Anil, recently the Healthcare Director General of Health Services issued a circular on the preventive actions that the healthcare organization should take in, with respect to look-alike, sound-alike medicines. Then at-risk behavior, which is like skipping a double check to save time, that is a little bit more than a human error. However, there you need coaching to improve awareness and risk. And if there is reckless behavior, like, for example, ignoring protocols deliberately, that is the situation where you need to take disciplinary action. So there are key concepts in just culture: fairness and accountability, where staff are not punished for human errors or near misses, and mistakes are seen as an opportunity to improve systems, not punish people. And you differentiate between honest mistakes, risky behavior, and negligence in taking action. And these things are done for open reporting, encouraging staff to report so that we can take preventive actions and you give a balanced response. So why is this just culture important? Because it encourages reporting of incidents and near misses and gives an opportunity to learn and prevent. And it reduces the culture of fear and blame in healthcare, which is inherently associated with risks. and it builds trust. I think the previous speakers talk about the trust. So it builds trust between staff and leadership and supports staff who are involved in genuine mistakes, who are identified actually as second victims. So who are second victims? They are healthcare providers who are involved in an unanticipated adverse event. Although patients are the first and obvious victims of medical mistakes, the doctors are also wounded by the same errors, and they are considered as second victims. And I think vast majority of here are healthcare professionals. So they are also, in the event of an unexpected adverse event, they are subjected to a lot of trauma. And in fact, many organizations actually support second victims. For example, Johns Hopkins has this RISE program, Resilience in Stressful Events, to support the healthcare professionals involved in these. And now before I finish, I would like to touch upon the Safety 1 and Safety 2 concepts, which is a shift in safety thinking. It is now in Safety 1, we learn from failures and errors where we try to make sure that as few things go wrong as possible go wrong. While in Safety 2, it ensures that as many things as possible go right. In fact, many things go right in healthcare settings, and there's a lot of opportunity for us to learn from that. So comparing Safety 1 and Safety 2, in Safety 1, we look at what goes wrong, Safety 2, what goes right. And the goal is to minimize adverse events in Safety 1, and Safety 2, we try to maximize successful outcomes. The role of humans in Safety 2 is as a resource, which is a source of resilience, and we learn from everyday work and successes in Safety 2, and it is a proactive and adaptive safety measure, while Safety 1 is a reactive measure. So in Safety 1 and Safety 2, in Safety 1, as given in the red box, you learn only from failures, whereas in 10,000 failures, 10,000 events, there is one failure, whereas there are 9,999 events that goes right, and you can learn from those. So in proactive approach, you identify and manage risks before the incidents occur, while in reactive ones, you respond after something goes wrong. So, therefore, in order to have a proactive approach, you need to address quality of care, which is the degree to which the health services and populations increase the likelihood of desired health outcomes, and it is aimed at health improvements. 7 elements of health quality of care, and of course the first one has to be, the healthcare has to be effective, but the second one is safety, avoiding harm to people during healthcare. So the requirements to provide good quality of care, we need to have high health workforce, excellence across healthcare facilities, and the medicines that we use has to be safe and effective in effective health systems and good financing mechanisms. Finally, the role of regulatory bodies in ensuring patient safety, enforcing qualifications and training standards, fitness to practice, responding to complaints, and supporting CPD. So the Sri Lanka Medical Council has taken these steps to ensure that licensing and regulation of practices, monitoring standards and ethical conduct, improving the educational standards, investigating complaints and disciplinary actions. Before I finish, I like to address the challenges that we face in Sri Lanka. There's a variability in CPD enforcement, capacity for timely investigations, and we need to coordinate between institutions. And I think establishing a just culture, which I mentioned, is a challenge for us, and particularly taking a proactive rather than a reactive approach to patient safety, and which is needed for increasing incident reporting. So the take-home message for patient safety, which is because healthcare is a complex and it is prone to errors, we need to simplify standards and procedures, train the health workers, involve patients in their care, ensure safe and clean environment, and promote reporting and learning from those incidents. Thank you very much.
Thank you, Professor Priyadashini Galapatti. Now, may I invite Dr. Pali Tabekon. He was the former head of accreditation unit of Sri Lanka Medical Council to speak on maintaining global standards, harmonizing medical education and accreditation.
Good morning, colleagues, friends, distinguished invitees. I particularly like to recognize our colleagues who joined the WHO meeting the last 2 days, many of whom are here, led by our friend from WHO, Dr. Ibadar Dillon, who is a tower of strength to all our work in Sri Lanka, not only in this, in many other areas. So I think we need to recognize you. Right. What I'll do in the next 10-15 minutes, Anand, please stop me if I'm taking time, because at my age I have no sense of time. So that's a problem. Please do that. I'm going to speak a little bit about global standards and the topic that they, but I'll try to relate it to the work we are doing or we have done in Sri Lanka, which might be more useful for an audience like this. Also touch on some of the issues that are also identifiable with what you said and which are relevant to some other countries also. How do you move this? Don't arrow. Yeah, thanks. Now, when I was reading up for this, for this little talk, I was looking at the medical councils around the world and a little bit of history of each one. And I was very pleasantly surprised but happy to see that ours, in the order of play, is the 4th medical council to be established in the world. I will show it to you. Of course, the mother council is the GMC, as you already heard. Medical Council of Canada was in 1912. New Zealand Medical Council was 1915. Thai was in 23. This is a little puzzling because all the other countries are Commonwealth countries which follow the GMC model, but Thais also were influenced by the GMC because there are a lot of their people going to UK at that time. And of course, SLMC in 1925. I don't want to go into the rest of it, it's just for our interest to Australian Medical Council. My colleague Martin is here. You're a young medical council, relatively sad to say. Now, what I will do is, I don't have to go through this because, this is what all of you are into, the Central Medical Mission of Medical Education. But I like to highlight 1 or 2 things. We are really talking about improving the quality of health care delivered by the doctors. What doctors can do and will do, when, where, and how well. And the quality of medical education itself is reflected by the knowledge, skills, and attitudes for the prevention and treatment of disease and for ensuring patient safety. So therefore, we all have a duty to get it right. What I will do next is to take you through some of the slides here, which will illustrate a few points that I want to make. Firstly, what do we mean by global standards? And why do we need global standards? Very simply, global standards represent the global expert consensus on standards for medical schools and for healthcare providers. Aim principally to ensure quality and to ensure patient safety. And it covers, as you know, basic medical education, postgraduate, continuing, everything else. Over the long years, it was the WHO that gave leadership, and more recently, a few other organizations like the World Federation of Medical, I'll talk about it a little bit later. The FAMA, the American group, which also has a lot of influence on medical education around the world, they are now onto it. Of course, I always say that GMC is the benchmark that we use in Sri Lanka for all these years. And to think that GMC, and certainly us, we didn't have any traumatic experiences like the Americans had in the beginning of the century with the Flexnerian reforms. Flexner, his report resulted in the closure of about 125 medical schools, so-called medical schools in America, because there were no quality control like what the GMC offered. Now, we hitched our wagon to the GMC, and until even before our medical council was established, we were following GMC, and we had recognition of the GMC, automatic recognition from GMC, until my medical school came up. That's only a coincidence, but nevertheless, until 1965, 70, both Colombo was all the time, Peradeniya was a few years. Then, of course, the situation changed and GMC changed their way of recognizing medical schools. Now, when you say harmonize, it's part of the title, harmonizing medical education accreditation simply means creating a global system of standards for evaluating medical schools, promoting best practices, and ensuring that all medical graduates meet a certain level of competence. It's a lot, but it basically says some kind of quality assurance. The object is to ensure comparable and consistent standards in medical education programs and products across different institutions around the world. Now, why do we need global standards? This is a very summary of what I think, which I try to capture the key points in this with regard to why we need global standards, primarily for quality assurance of our own medical education and for safeguarding the public. I keep repeating that. Secondly, also, to harmonize international migration and international study and research collaboration. I use the word migration before study because, it's something that is very current in our discussions. Medical education, as we all know, has become a very valuable commodity. And standards are needed for student placement and student movement. And also, global standards give us a basis for accreditation and for national comparison. What is the current relevance of global standards to us and to the world? First, I'll show you the health workforce shortages around the world. This is in the NHS. This is in the US. This is in Japan. And this is in the OECD countries. And a little bit more on this. With regard to the OECD countries, which I think number about 32, but within the OECD countries, what I am talking about applies to maybe 10 countries, the richer countries. This is the situation, and it's growing. The growing disparity between the requirements and the production. It's not getting less. We were talking of the code and all that yesterday. So the challenge of the code is, one of the challenges is this. As we move on, the number of doctors and nurses required in the rich countries is increasing, and we are not catching up. I'll show you one or two more pictures and I'll move on. This is with regard to the migrant health workers, both foreign-born and foreign-trained, which is increasing in the OECD countries. So, for example, right now, according to this, and this may be not totally correct, but it's at least approximate, foreign-born doctors in the OECD countries is about 30%, about 1/3, foreign-born. Foreign-trained doctors in these countries is about 20%. And when you take numbers, individual numbers, it becomes a large amount. And similarly with nurses, 18.4 and 8.2. Now, this is the local scene. I picked this up, randomly in the last month or two. But they tell a good story, and these are good data, because GMO produces very good data. They say, ගෙවුණු වසර දෙකේදී 2000ක් රට හැර ගිහින්. In 2 years, that's, in a country which has 18,000 functional doctors, 2,000, I would say is a significant number. Then also, more authoritatively, the Honorable Minister at the World Health Assembly, I got the clip, he said this: over 4,600 health professionals have migrated since 2022. This was just 1 month ago. So we have an issue which we can't ignore. At least we need to take cognizance of it and see how we address it. then where do these health workers migrate? Why do health workers migrate? I'm not going to spend time on this, usual thing, push factors in where you are and the pull factors in the countries where you go to. And there are many, many reasons for it. In the larger context, I think the living conditions and the education of children predominate as their reasons for living. But I believe there's much we can do, including the Medical Council and the Ministry of Health and the government, to improve the conditions of these health workers so that the push factors, we reduce or diminish them as much as possible. Pull factors we can't control very much, but the push factors we can control to a large extent. Then I want to also take you very quickly through the students of Sri Lankan students who are going abroad for studies and who are coming back from their studies. I have the figures of the last 10 years from the SLMC. I draw the line at 300. These are the degree approvals. These are not people who come back after their degree, but these are the people who get letters, what you call, there's a name for it, letter of whatever, which they take. Letter of good standing, thanks, yeah, which they take. So you see, we see every situation needs more than 300 every year. But in some years, it has been around 800. Then you come to the second part, those who come back and sit the ERPM and pass, not just sitting, more will be sitting, but these are the ones who complete. When you look at it, the numbers are pretty big. So I have this on tabular form. If you look at this, the people who come back, 588 in 2022 have come back. 487 last year, 296 this year, because we had only one exam, I believe. There's one more exam to come. So we are exceeding 500-600 doctors coming, and we are exceeding now 800 children have wanted to go out in 2024. So sometimes I wonder, we are talking of almost 3 or 4 medical schools going out and coming back. 3 or 4 of our medical schools going out and coming back. Very significant. I mean, I just note them, and it's up to all of us to think about it. And these are the recognized medical schools. We had much more, but now the SLMC has pruned down, got the wherewithal and the quality of this education. Now we are 24 or 23 or 24. I won't go into that. Now, what I want to move on to is to see what is our response to this migration and the issues that we have. The main responses to migration and cross-border education have been mainly 2. One is, of course, the WHO Code of Practice on International Recruitment of Health Personnel, which we talk about for the last 15, 20 years. There are positives, but I don't believe it has had a major effect on the movement of people from developing countries to the developing countries, not yet, because it's a voluntary code. Then, of course, we have been developing accreditation quality assurance systems, mainly for doctors and less so for 5. Yeah, I'm finishing, I'll take a little more. This I will not go into. Accreditation for us is to certify the competence of practicing doctors and to ensure patient safety. This is the World Federation which we are affiliated to now, which was made up of, I thought I saw Dujipa here. Yeah, Dujipa is one of the council members of this from the Western Pacific region. He's a very active member of the World Federation. So they were here. World Federation was formed between the World Health Organization, World Medical Association, and the 6 WHO regions having 1 rep and a few others like students reps. Yeah. Their main programs are these. There are 3 transformative milestones for SLMC which changed the course of our work. And these you recall and you recognize. First is the publication of the Gazette of Minimum Standards, which gave the legal sanction to do many of the things that we do in accreditation. Secondly, the ECFMG decision that in 2021, from 2023, it became 2024, it has not come yet. Doctors applying for ECFMG certificate at work in America will be required to graduate from a medical school that has been appropriately accredited. Now, we didn't get excited, but we got interested in this because a lot of our children are going out, not migrating alone, but they go for studies because it's mandatory for Sri Lankan doctors to spend a year or so outside the country in a place of excellence. So the Medical Council was very proactive, and they made the resolution on the 30th of August 2019 to set up the accreditation unit to work towards getting World Federation. Not only that, to work towards setting up a quality control system, accredit the local institution most of all, and also to try to obtain World Federation as soon as it could. And this is the first unit that came up, and many of them are here. Gominda, I don't see here, but many of them are here. And this is the President of the World. Day before yesterday, he sent me a message, recorded message. He thought this message he sent, I will not play it, wishing us well. This is the diagram of the countries where the World Federation has recognized the national accrediting authorities. There are about 65 countries and about 75 what you call authorities, because some countries have, like the Caribbean, have one authority, but they accredit about 10 schools. So it's a large number. Yesterday I was told India has applied, they are waiting for it. Nepal has applied. From our region, it's only Thailand and Indonesia, which are recognized, and we are the third. We have a accreditation committee, which is a larger committee, not the unit itself. Unit is now 6 people. This committee is the one that gives the context and looks at it from a contextual and broader perspective than the technicalities that the accreditation unit looks at. And that has been very helpful because they bring experiences and expertise and perspectives that we sometimes tend to miss. This is the way we do, and I'll just go through the process, which is not very important. It's like the regular process that you do in medical schools all the time: self-reporting, visiting, and discussion and making a decision. And we look at the usual things. I will not spend time there. These are the schools which are accredited fully in Sri Lanka, 9 schools. 4 are on the way, 2 are almost there, I think, and 2 are close to, but one, there's a private medical school which has also requested, which has not been taken up so far. And I'll finish with this time. For the accreditation unit, which I think is an essential part of the Medical Council, it also has to look at its governance, particularly to obtain legal sanction for its work, which I believe in the new act will happen. Then, of course, it has to support and promote curricular innovations, which we discussed some of them already. It has to keep up with the developments around the world. And this I want to mention. I think SLMC also has to join this regional. I think it's worth joining the regional, be a partner of the regional network, which is being set up now, because there's a lot of mutual exchange, learning, South-South learning, that we could benefit from that, and also work with the other medical councils and accrediting agencies outside the region. So I would like to end by saying this. In the coming decades, we must make the SLMC not merely an institution that we like to live with, but an institution, not merely an institution that we want to live with, but an institution that we cannot live without. I think we should be thinking of moving in that direction. And I wish the SLMC, I won't say 100 years because this should be more than 100 years. GMC is now already 300 years, so many, many centuries of development and support to maintain the standards and look after the safety, health and safety of our people of this country. Wonderful job so far. I think we got to keep it up. Thank you very much. I'm sorry if I took a couple of minutes more.
Thank you very much for that wonderful overview. And thank you very much for your wishes. You have been a strength for all of us, not only the Medical Council. Now may I invite Honorable Justice Yasantha Kodagoda, Judge of the Supreme Court, to speak on strategies for addressing malpractice in healthcare system, which I think is a very relevant and current topic for all of us.
The chairman of the session, Dr. Anand Vijay Vikrama, my co-resource persons, Dr. Palita Bekon and Senior Professor Priyadarshini Galapati, distinguished participants, ladies and gentlemen. I consider it a privilege bestowed on me to address you this morning at this landmark conference organized to celebrate the centenary of the Sri Lanka Medical Council. The SLMC, as we all know, is a highly responsible body that has, for the past 100 years, stood ground, functioned as a statutory body of utmost importance, and performed its fourfold mandates to a high degree of integrity. The focus of this paper, ladies and gentlemen, is on the third of your four functions, and that being upholding ethical medical conduct through the enforcement of structured disciplinary processes. That being the responsibility you are required to uphold in terms of the law, I would think your function is quasi-judicial in nature. And I think it is important to highlight that, particularly because most regulators fail to appreciate the importance of your function being quasi-judicial. Quasi-judicial really means that you are in fact an alternative, a viable alternative to what courts are called upon to do. The difference being, courts engage in judicial adjudication and you perform a different form of adjudication, which is really not judicial. But let me reiterate that it is important on this momentous occasion for you to keep in mind that your role is in fact quasi-judicial in nature. And that means, among other things, the need to be equidistant from both the professions that you regulate and the public at large. Ladies and gentlemen, as you reflect on your achievements, I would imagine that the purpose of this conference is not merely celebratory and self-praise. A centenary is also a moment for introspection and looking back at your own past. In the same spirit of celebrating this milestone, I invite you, ladies and gentlemen, to look inwards and also towards the next 100 years with openness, objectivity, and sincerity. I urge you to carefully consider whether there was opportunity for the SLMC to have done better, and consider whether there is scope to improve the efficacy, efficiency, and integrity of the SLMC's investigative and inquisitorial functions into allegations of professional malpractice by fellow members of your own profession. Such reflection, ladies and gentlemen, should, in my view, not be considered as self-harming. It must be seen as stemming from the visionary leadership being provided by the Sri Lanka Medical Council to the medical profession and arising out of your unwavering and sincere commitment towards protecting public interest and, of course, the best interest of your own profession. Ladies and gentlemen, to anchor our discussion this morning, it may be helpful to briefly recall and reaffirm the legal and ethical obligations that define lawful, ethical, and professional conduct in medicine and surgery. Let me list them before you in a very concise manner. Number one, respect for patient autonomy. This would include obtaining consent and maintaining confidentiality of patient information. Number two, the principle of beneficence, which means always, and I repeat, always acting in the best interest of the patient and only doing good to the patient as opposed to thyself. Number three, the duty of non-maleficence. That is not doing any form of harm, pecuniary, health-wise, or in any other form to the patients. Number four, justice. That, ladies and gentlemen, is a difficult balance. While treating your own patients, to keep in mind the best interest of the other patients as well as the community at large. A very delicate balance. Number five, professional and competent medical care. Number six, professional due diligence, as I would like to call it, which really means attentiveness and adherence to a high standard of professional care. And of course, as you would appreciate, the flip side of that is the absence of negligence. Number seven, compliance with statutory and regulatory requirements applicable to medical practitioners. Our law confers on medical practitioners certain statutory and regulatory obligations that they must comply with. Number eight, fulfillment of contractual obligations towards patients, towards respective employers, and the healthcare services institution at which you decide to discharge your professional services. Number nine, adherence to the law of the land to the extent it binds all of us, both medical as well as non-medical citizens of this country. And finally, number 10, refraining from engaging in any conduct that would bring the individual concerned as well as the medical profession into disrepute. Now, why I thought of going through this list of 10 principles, ladies and gentlemen, is because, as I understand it, it is in fact one out of those 5 primary responsibilities of the Sri Lanka Medical Council to police adherence with these principles. A breach of any of these 10 overlapping principles, whether legal or ethical, would not only endanger the interests of individual patients and the medical practitioner himself, it would also affect the community at large. It would also erode public trust and confidence in the medical profession, which would in turn affect the very foundation of effective health care. Ladies and gentlemen, as we all know, the SLMC is statutorily empowered under the medical ordinance to investigate and inquire into allegations of professional misconduct. And I am aware that the term that you use is malpractice. Be that as it may, whatever might be the nomenclature, I reiterate my view that your statutorily conferred responsibility is to police adherence with all 10 principles that I referred to. On this very important occasion, ladies and gentlemen, I would urge you to pay attention to the fact that there is, in fact, growing public concern that the current procedures and practices being adopted by the SLMC are slow, opaque, and at times perceived to favor medical professionals who are accused of having committed malpractices. The accusation being that the SLMC adopts what I would refer to as a protectionist approach towards medical practitioners against whom allegations are made. I hope you would appreciate that these concerns are, in fact, not accusations by me, nor are they claims backed by empirical evidence. However, we cannot overlook the reality that these views are deeply held perceptions by knowledgeable segments of the community at large. You would appreciate that, especially for the reputation and respect of learned and honorable professions, such as medicine and surgery, public perceptions do matter. On the other hand, ladies and gentlemen, on the flip side of that perception, you may well find that medical professionals under scrutiny by the SLMC may feel otherwise. They may entertain the perception that the prevailing system is harsh, inappropriately adversarial, overtly punitive, and unnecessarily injurious to their professional reputation. Perhaps, ladies and gentlemen, a review of outcomes of investigational and inquisitorial proceedings of the SLMC, which, according to your terms, would mean outcomes of the preliminary proceedings committees and the professional conduct committees, and associated data and information can shed light on this divergence of opinion and offer an evidence-based conclusion. In fact, in my view, it would be timely for the SLMC to commission the conduct of an empirical research founded upon an exit survey and the conduct of randomly selected case studies. If regulators and disciplinary authorities of medical ethics are perceived as being insular, biased, and slow to act, the very authority they seek to uphold may be undermined. In my view, reform should neither be viewed as an admission of blame or a plea in mitigation. Your resolve to change should be seen as a reaffirmation of principles which you espouse and your integrity as being leaders of the medical profession. And with the medical ordinance currently under review and not yet reenacted by Parliament, you are perhaps at the most opportune moment in history to overhaul the system in the best interest of the medical profession and the public at large. I hope you would understand, ladies and gentlemen, the duty of conducting investigations and inquiries lies squarely at the SLMC And that is why it is seldom that one would hear of a law enforcement agency, such as the police, undertaking the conduct of an investigation into an allegation of professional misconduct. The key principles, ladies and gentlemen, that will govern the integrity and the relevance of the outcomes of both investigations as well as inquiries would be compliance with the rules of natural justice, objectivity, and fairness in your conduct. With those principles in mind, ladies and gentlemen, I wish to propose 4 sets of reform to both investigations as well as inquiries being conducted. I have segmented them into these 4 parts aimed at enhancing procedural integrity, which is critical, strengthening neutrality and representation, ensuring compliance with timelines and transparency, and finally, modernizing sanctions and corrective measures the SLMC may wish to impose. Under enhancing procedural integrity, I would respectfully suggest that you consider establishing a complaints secretariat not only to receive complaints by the public coupled with an affidavit, as well as a report from a public servant, which carries a very narrow interpretation, but your ability to act on information which is deemed to be credible contained in media and other public reports. Your ability to engage in surveillance and undertake suo motu investigations. Those are investigations that you will initiate on your own motion based on valid grounds, would also be very important. I would think that it would be critical for the complaints secretariat to enjoy considerable autonomy from the rest of the council. Second, a suitably empowered investigations unit. I would think it is timely that one appreciates that investigation and investigations are to be carried out by professionals who have the training, the competence, and the experience to undertake and carry out investigations. I would, with the greatest respect, submit, though the expertise of medical professionals will be useful for the conduct of investigations, investigations must be carried out by persons who are independent from the profession and suitably empowered to carry out their functions. We live in an era where the SLMC is likely to get a large number of complaints, and therefore, I would suggest that complaints be categorized so that you can decide which type of complaint ought to receive the priority and proactive attention of the investigative unit. Fourthly, permit prosecutorial discretion. Ladies and gentlemen, following the conduct of investigations, you must, if you are interested in integrity, you must confer the responsibility of deciding on whether or not further proceedings are to be conducted to an independent, in-house prosecutorial authority. We then move to, ladies and gentlemen, the second segment, strengthening neutrality and representation. I would think there is a need to ensure that panels appointed to conduct inquiries are comprised of independent, non-elected professionals who constitute members from several disciplines, including, of course, the field of medicine. So a multidisciplinary, independent, and therefore non-elected set of professionals, of course including experts from the field of medicine, to constitute the inquiry panels. Thirdly, timelines and transparency. I have had the occasion to look at some of the statistics, and your statistics, I will very openly say, is no better than the statistics of courts of law. And therefore, we all have to move towards fixing definite timelines. Finally, modernization of the sanctions regime that the SLMC should be empowered to impose. In addition to the present only 2 available sanctions of complete erasure and suspension, I would suggest that you consider empowering the SLMC to impose the following: naming and shaming, of course, where appropriate, written warnings and causations, mandatory requirements to participate in continuous professional development programs, imposing of compensation orders. I say this, ladies and gentlemen, with a particular reason in mind. If the SLMC upgrades the integrity of the investigation and inquiry process, and if the SLMC is empowered to impose orders of reparation in the form of payment of compensation to victims, it is likely that the victims will choose not to go to courts of law and haul up medical professionals in litigation proceedings, which can be time-consuming, highly stressful, expensive, as well as risky. If compensation is available from the SLMC itself, it is likely that we will see a reduction in litigation relating to alleged matters of medical negligence. So with those suggestions before you, I wish you all the very best, and we will all look forward for a better century. Thank you very much.
Thank you very much for that wonderful lecture, and also very important suggestions, especially at this juncture where we are formulating the new act. So those will be, I am sure, will be looked upon positively with the Sri Lanka Medical Council. Once again, thank you very much. And I take this opportunity to thank all the plenary members, Senior Professor Priyadarshini Galappathy, Dr. Palita Abeykoon, and Honorable Justice Jasantha Godagoda for giving their invaluable views on this important occasion. Thank you.
May I now invite the session chair to present tokens of appreciation to our distinguished speakers, and kindly request the speakers of the second plenary session to come forward. Professor Priyadarshini Galappathy. Dr. Palita Abeykoon. And Honorable Jasantha Godagoda. And I would like to invite Professor Ranil Fernando, Chairperson of the Centenary Celebrations Committee, to present a memento to the session chair as a heartfelt token of our appreciation for guiding and moderating this session. Thank you to our distinguished dignitaries for your presence and participation. You may now kindly take your seats as we proceed with the next item on the program. And we now transition to a panel discussion titled Medical Ethics, Professionalism and Regulatory Challenges. And it is with great honor that I invite Dr. Suresh Shanmuganathan, who is a senior lecturer and head of the Department of Oral and Maxillofacial Surgery at the faculty.
We had two excellent plenary sessions. Now we come into the panel discussion. So we need some time to have some discussions. I'll cut down the introduction, keep it sweet, short and sweet. So these are panel discussions are basically on building trust between regulators, clinicians, and the public. And the first speaker today will be Professor Anuja Fernando. She is the Emeritus Professor of Pharmacology from Faculty of Medicine, University of Ruhuna. And she will be speaking to us on navigating ethical complexities in modern medicines. Over to Professor Anuja.
Thank you, Dr. Suresh Shanmuganathan, President and members of the Sri Lanka Medical Council, distinguished invitees, ladies and gentlemen. I would like to thank the Centenary Celebrations Committee for inviting me to make a presentation today at the academic sessions. It is a privilege to have this opportunity to be a part of the Centenary celebrations. I offer my congratulations to the SLMC for its role in maintaining the high standards of medical education in our country, for which I think Sri Lanka is fairly well known and recognized. I also extend my best wishes to the Sri Lanka Medical Council for the next 100 years. As mentioned, I don't know if it was mentioned, but I was a member of the council for several years, and I remember those years well, when I used to be the only member not required to wear a tie. How do I define modern? How new should a medical procedure or discovery or innovation be to be called modern? A little difficult to know exactly where to begin. So I thought I would begin at the point when medical ethics was more or less forced to become modern as a result not only of scientific and technological advances in medicine, but also due to the social, cultural, and political changes that took place around the world in the middle of the previous century. If we look at the evolution of Western medical ethics over the years, we obviously start with Hippocratic medical ethics, which included the ethical principles of beneficence, non-maleficence, confidentiality, and even competence. I think some of them were explained very clearly by President Council, Yasanta Godagoda. Now, the ethical principle of respect for life was emphasized in that abortion was prohibited and euthanasia was also prohibited to physicians. To quote from the Oath of Hippocrates, this is the part that says that, I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. Similarly, I will not give to a woman an abortive remedy. In purity and holiness, I will guard my life and my art. Now, so these two, prohibition of abortion and euthanasia, emphasizes a moral attitude that was prevalent at that time, and that is sanctity of life, inviolability of life. And these are later associated with religions, where sentient life was considered to be sacred and inherently valuable and deserving of protection. In Christianity, human life was valued above all other living beings because humans were said to be created in the image of God. While it was permissible to kill animals, killing humans was forbidden, which is a sort of an anthropocentric view. In some Eastern religions, such as Buddhism and Jainism, all living beings were held sacred, and the practice of ahimsa, or non-harm, was extended to animals as well, which is a more ecocentric worldview based on coexistence with other living beings. This principle of sanctity of life lies at the heart of future debates over abortion and euthanasia. The scientific and technological advances in modern medicine, together with several significant historical events that took place in the mid-20th century, such as the Second World War and its aftermath, led to ethical challenges that transformed medical ethics into the newer field of bioethics. Now here, ethical principles and values that existed for hundreds of years from the time of Hippocrates were challenged by issues such as dramatic improvements in intensive care and life support systems, and the discovery of high-tech drugs, vaccines, which kept patients alive indefinitely, and demands for legalizing abortion, organ transplantation, assisted reproductive technologies, and widespread engagement in research on humans. To expand a little bit more on these, some of these challenges, for example, medical experimentation. Huge spending on research by pharma companies and research institutions led to conflicts of interest and also caused harm to research participants. Then there were the blatantly unethical medical research conducted without informed consent, such as the Tuskegee study in the United States and the experiments carried out by Nazi Germany during the Second World War. There's also the expense of high-tech vaccines and drugs, newer drugs, antibiotics, which would have led to, the expense would have led to inequity. They may not have been easily available to all the people in the country. They wouldn't have been able to afford it. Then the newer procedures like hemodialysis, intensive care, and so on, again, would have been very expensive at the beginning, and again, would not have been easily available to all the people in the country. Organ transplantation, some would have led to a situation where the demand was more than the supply, and that has led, as we know, to unethical practices, which has even resulted in stealing of organs from people in other countries and buying organs from poor people in other countries, and many unethical procedures like that. End-of-life issues are also very important, and they have given rise to a large number of ethical challenges, as you all know. There's no time to go into details of all that. DNR orders, termination of life support, and so on. So all these, I'll come to DNA and ART a little later. But in addition to these scientific and technological advances, there were, as I said, also political, social, and cultural factors. For example, the rise of feminism, which led to demands for abortion. Then, of course, there were the protests against discrimination and inequity in certain political systems in certain countries, such as segregation, apartheid, and demand for independence from colonized countries, mostly Asian and African, and also limited resources for provision of adequate health care. And also, these are just a few of the issues that would have added to these ethical challenges. To go back to the genetic revolution, now it's important when we talk about, this is of course not new, but whenever a new discovery or innovation or issue comes up, we should learn how to identify the ethical issues in that area. So just to briefly tell you what are the main ethical issues that arise from the genetic revolution. The expense, the increasing use of genetic tests and the expense of it. And is it really useful? Are we just doing tests for research purposes? Are they useful for the parents? Sometimes they may not be able to afford these very expensive tests. And are we doing proper genetic counseling? And we have to remember that they also have a right not to know. They don't always have to know. They may not want to know that they may get Huntington's chorea when they are 50 years old. They would much rather live happily without having that knowledge, and so on. So we have to identify these ethical issues in these newer technologies. And if I go on to some of the ethical issues in assisted reproductive technologies, these also have been here with us for some time. They're not all that modern. Donor anonymity versus right to know. When they first started donating gametes, donors were kept anonymous, but now everybody wants to know, so they go around trying to find out who their father is, which can lead to a lot of problems. So these are, without going into too many details, these are some of the ethical issues in assisted reproductive surrogacy. Surrogacy also has given rise to a lot of ethical issues because, you know, it's not available in all countries. So if it is not available in your own country, they go to another country where it can be done. For example, an Australian couple went to Thailand, and the Thai woman was expecting twins, but one of the twins unfortunately turned out to be a Down syndrome baby and was rejected by the couple who wanted it. So the Thai mother had to look after this baby. So things like that can lead to a lot of problems. The mothers who are, of course, doing it for payment, but yet they are very vulnerable in this situation. And there are lots of other things like the age and so on, who should have it, these sort of things, so on, who should pay. And of course, I think somebody else is going to talk about regulations. But countries like India and Thailand, they are very worried about this. India, for example, passed regulation. For example, they are very clear who can rent an Indian womb, rent a womb. So they are very specific who are the sort of people who can actually rent an Indian womb to have a surrogate baby. So to get back to this slide, to navigate these ethical challenges, new concepts such as autonomy, resulting also in concept of informed consent, justice, and equity were introduced into these new ethical principles. As I said before, these are mainly after the Second World War with the introduction of the Universal Declaration of Human Rights. And also animal ethics and environmental ethics were also introduced into bioethics, so that it's a much wider field which includes medical ethics as well. However, it appears that respect for life itself may have been minimized or got a little bit less, because now we no longer have abortion being prohibited. It's legal in many countries, and Also, euthanasia is also being legalized more and more in more countries. UK, for example, have just started their debate on that, I think, and also in Canada, Montreal, I think. So national and international ethical guidelines. So these are some of the modern bioethical. With each new innovation or discovery or technological advance, we have to think of new ethical principles. COVID pandemic, for example, made us realize the importance of public health ethics and these important ethical principles of non-discrimination, non-stigmatization, cultural diversity, pluralism, solidarity and cooperation, production of vaccines, sharing of research results, and so on, social responsibility and so on. All these we think of, not that pandemics are a sort of a modern thing, we have had them long ago, but the response to the pandemic, I think, was in a slightly different way because we had all these facilities available. So we do have international ethics guidelines such as these, World Medical Association, Declaration of Geneva, and Declaration of Helsinki for research ethics, and UNESCO has produced several international declarations on bioethics. So these are, oops, sorry, I'm going the other way. Now, I am not going to talk about AI or the neurotechnologies or robotics or anything like that. I think there is no time for that. But in the new millennium, modern medicine has even become more complex. And data banks, biobanks, digitization of medicine, use of big data, all these present ethical challenges. So how do we navigate all these? Well, we can follow a sort of a certain pattern, basic pattern, just the way that we tackled research ethics, which we have done fairly well, I think, because research has to be done by everybody, and it has to be published in international journals, so everybody is very careful about doing it ethically. So just the way that we tackled research ethics, we can tackle any new innovation or discovery or technology that comes in. So we have to first understand this modern technology or discovery or whatever, understand it properly, educate the health professionals about it. The most important thing is to identify the ethical issues. And here we must identify these ethical issues which is relevant to our own country. We can't just follow what other Western countries are doing, for example, because culturally we may have slightly different views on, say, autonomy, for example. So we have to pay attention to the feelings and thinking of our own people when we deliberate on these issues. But the main thing is once you identify the ethical issues and once you go on to practice this so-called practice or use this so-called innovation or discovery, we have to try and maximize the benefits and minimize the harms, just as we do for research ethics. Then are there guidelines available? Regulations are not available very easily, but guidelines usually are. If they are not available, then we should develop them so that we can use them. Then follow the guidelines. If there are no ethics committees at the moment dealing with that particular subject, then we should establish ethics committees to monitor how we are carrying out this new thing. Train the members of the committees, not only the people who are doing this technology, but also members of these ethics committees should be trained. And very important, we should educate the public because they should, I think this is something that we don't do very well in Sri Lanka. I don't think they know very much about any of these things. So I think there should be some mechanism where our people are educated about these things. And it's really important because we should be able to empower them to recognize their rights and exercise their autonomy when they are faced with all these complex choices that are available in modern medicine and healthcare. So I think I should maybe stop there and take part in the discussion if there is any. Thank you.
Thank you very much, Professor Anuja Fernando, for highlighting the issues related to the ethical complexities in modern medicines. Next, may I invite Professor Dame Kerry McEwan, who all the way come from Scotland. She is the chair of the General Medical Council of United Kingdom, and she is also the consultant ophthalmologist at the Tayside NHS, as well as the honorary honorary professor to the University of Dundee. She was appointed as the Dame Commander of the Order of the Order of the British Empire for the services to ophthalmology and healthcare, leadership during the COVID-19 response in the Queen's Birthday Honours List in June 2021. She will speak to us on building trust between regulators, clinicians, and the public. Over to you, Professor McEwan.
Thank you very much for that kind introduction, and thank you everybody for giving me the opportunity to be here to join you to celebrate 100 years of the Sri Lanka Medical Council, and amongst such auspicious company. I bring warmest congratulations from all at the General Medical Council on this momentous occasion. And it's a huge pleasure to be here with you. I've enjoyed what we've had so far. I've really enjoyed the presentations, and I know there's going to be more rich discussions to come throughout the day. As already mentioned, I chair the General Medical Council, and that is the UK regulator of doctors. And until 6 months ago, we only regulated doctors, but now we've been given the responsibility of regulating physician and anaesthesia associates. That's fine, thank you. So my job today is to talk about trust, and why trust matters for regulators, for clinicians, and for the public, and how that can make or break the relationships that are vital across all three of these groups. Trust, at its most fundamental level, is about the bond between individuals and those individuals and the institutions that shape their lives. It's an incredibly precious commodity, and one that once lost is hard to regain, and it needs to be constantly tended to and topped up. In today's internet-enabled age, when the currency tends to be outrage, falsehoods, whether intended or otherwise, these are disseminated with ease, and that makes trust all the more fragile. In fact, more so than at any time I can remember, there is this prevailing cynicism that means those of us in positions of responsibility have to work even harder to win trust. But it's absolutely vital that we do. And the reason for that is that without trust, doctors can no longer have meaningful relationships with their patients. Patients can't have confidence in what their doctors tell them, and regulators cannot fulfill their duty to the public effectively. So fostering trust across all of these relationships is critical if the healthcare system is to run smoothly. But it takes work, and it takes a willingness to recognise when that trust is lacking, why this might be happening, and how we can take steps to restore it. As doctors, the great privilege of our profession lies in a patient putting their health and sometimes even their lives in our hands. Sometimes sharing with us very private and personal information at very short notice, and permitting us to use our skills to make a difference to them. And some of these skills involve uncomfortable and invasive procedures. These interactions are inherently acts of trust, both precious and essential. But they can also be subject to forces outside our control as clinicians. Today, doctors are no longer the sole gatekeepers of medical knowledge and information. For instance, in my own practice, I've seen how with easy accessibility of the internet means that patients quite commonly come to me armed with their own analysis of their condition. And that, along with that, comes higher expectations over how they should be managed, sometimes just coming to affirm their own diagnosis and to be treated the way they want rather than to consult. That patients feel empowered in their interactions with doctors is obviously a good thing. And the ability to take ownership of one's health is something that most of us would encourage. Rather than being the passive recipients of care, most of today's patients want themselves and their families to be at the centre of decision-making and to understand fully what that and how it affects them. And that is a right thing to do. But while that free flow of information has many benefits, it has also opened up a space for what I would describe as actors who lack the education, the training, and the regulation that all doctors are subject to. And social media means that unevidenced scaremongering and often prejudicial information can disseminate at an alarming rate. We saw this most clearly during the pandemic, and of course the vaccine hesitancy that's accelerated following this. These are global, epoch-defining trends. What are mere regulators going to do about them? How can we get over this task without it being overwhelming? I believe we have a number of tools at our disposal, and in contrast to the modern phenomenon I'm describing, the answer is perhaps the most fundamental, established one in our arsenal, and that is how we as doctors behave as professionals. In short, it's not just the care that we deliver, but the way we go about doing it, and that is what defines for the patient their experience. It's how we listen to patients. It's how we articulate our course of action. And it's how we show that we care and we understand for them and their circumstances. This is what's often described as soft skills, like listening, empathy. These are as material to a patient's care as surgical skill or diagnostic ability. But while their importance has been increasingly recognised in recent years, there's still a sense that these soft skills are nice to have, rather than being absolutely critical part of a doctor's toolkit. This is something that has to change. Trust is a process that involves action. So like anatomy and physiology, communication and leadership must be core to the medical student's curriculum. This is something that we at the GMC are driving forward in our work with medical schools and healthcare employers within the United Kingdom. Because it not only matters acutely to the doctor-patient relationship, but also the relationship between doctors themselves and their entire healthcare team. A psychologically safe environment where doctors feel free to speak up and to ask questions requires trust between colleagues. Where this is lacking, doctors may feel that they're unable to ask for help or to escalate the concerns that they have. And they may be concerned about this for fear of the consequences because they do not have trust in the entire team. Now, this inevitably goes to the heart of patient safety, and it really must be given the risk that it deserves. So what about the role of regulators? Well, we as regulators have a critical part to play in this as well. Our ability to influence is directly linked to the trust that we have with both our registrants and with the public. They need to trust both of us in our work. And we've already heard this morning the two different perceptions between what the public may think of the regulator and what the profession may think. So for patients, they need to be able to trust the regulator to uphold the standards as being a key part of the trust in the healthcare system as a whole. Now, this relies on patients believing that we will ensure that the doctors treating them have the correct knowledge, the correct skills, and the correct behaviours, and that we as a regulator will take action if that education, practice, or conduct of those treating them falls short of these standards. But not only that we will do so swiftly, we will do so effectively, and we will do it without fear or favour. And for the profession, the pride of being a doctor is partly driven by the preservation of these high standards and that knowledge that we're working in a field where skill and professionalism matter and are valued. But if the doctors don't trust their regulator, why should they adhere to the standards that we set? Of course, the dynamic between the regulator and those it regulates is often thornier than the one between the regulator and the public, largely because upholding standards means intervening when they're not met. And for the profession on the receiving end of such decisions, some may be critical over the judgments we make and the way in which we do that. Being critical is one thing, and we must listen to criticism, but much more damaging than that is fear. Fear that their careers may be damaged, fear of the impact that any investigation may have on their families, fear of long, difficult processes, and fear of being treated unfairly. Now, this matters. It matters because it can have a psychological impact on doctors, and that effect of perception spreads amongst the profession. But what really matters here is that it has an effect on patient safety. Fear is not conducive to good outcomes. Doctors who are fearful may act defensively rather than in the best interests of the patient in front of them. They tend to over-investigate, they tend to over-treat, and commonly they fail to make urgent decisions. So in everyone's interests, we do not want those we regulate to fear us, or, in short, distrust us. And that's why we, at the General Medical Council, have been changing the way that we regulate. And that emphasis is on minimising fear and increasing trust in all involved. So how are we doing this? Well, it's not by being weak and failing to take appropriate action when it's required, but by demonstrably taking action that is visible, it's swift, it's fair, it's relevant, it's effective, and above all, it's compassionate. Achieving this requires an entire shift in the organisation mindset, from the tone that we use to communicate with doctors and to the public, to the speed with which we respond to their queries and complete their investigations. We are pursuing a model of regulation that puts compassion at its heart. Remember, medical councils do not exist to punish doctors or to treat them, but to treat them as professionals and to promote and protect and maintain the health and safety of the public. So that prize, we hope, can be achieved and will be felt when we are able to be trusted. Ladies and gentlemen, nothing in medicine stands still. We've already heard that in our previous talk. And all healthcare is intimately tied to the shifts in wider society. So we need to be responsive in order to constantly adapt and evolve. But whatever the changes that shape and shake us up in medicine, at the heart is the bedrock of trust, because without it, frankly, all is lost. So across all who provide healthcare, that's regulators as well, and patients that we serve, we need to identify that trust is the glue that holds everything together. And it's essential if we are going to share safe, patient-centred care. And I know that from hearing what's happening in Sri Lanka, that things are going to continue to evolve in a way that, reflecting on the past century, you're going to look forward to the next century with hope, with trust being at the heart of that. Thank you very much.
Thank you very much, Professor D.M. Kerry McEwan. And also thank you very much for keeping to your time. I'm sure that all would agree that building trust between regulators, clinicians, and the public is most important, is fundamental in having a well-functional healthcare system. Next, we have Dr. Sunil Abeyratne, Senior Attorney at Law, to speak to us on regulating technology in healthcare. Dr. Abeyratne.
Good morning. Thank you very much for introducing me at this centenary celebration of your organization. And once again, thank you very much to invite me to share my knowledge and the contribution from legal profession for the betterment of your profession. Ladies and gentlemen, I will not discuss main regulations relevant to your profession. I will briefly make my contribution, especially on the required regulation in future under the development of ICT sector. Technology is developing, we can't stop it. The day by day scientists are going for new technology. Information and communication technology is one branch of technology. Technology integration in healthcare is a revolution as far as patient care. Medical research and operational efficiencies are concerned. From electronic health records to telemedicine and artificial intelligence diagnostics, technology plays a critical role in modern healthcare. However, this rapid advancement also brings challenges related to regulations, safety, privacy, and ethical considerations. Effective regulation is essential to ensure that technology enhances healthcare delivery without compromising patient safety or privacy. So what are the key areas as far as regulation in the health sector is concerned? Firstly, data privacy and security will play a vital role. Regulations like the General Data Protection Regulation, we call this as GDPR in European Union, and the Health Insurance Portability and Accountability Act in the United States provide standards for the protection of personal health information. Compliance with these standards is crucial for healthcare providers using technology to manage patient data. In the meantime, cybersecurity also will play a vital role in this mission. As healthcare systems become more digital, the risk of cyber attacks increases. Regulations must enforce robust cybersecurity measures to protect sensitive health information from breaches. The Sri Lanka's Personal Data Protection Act, it's a brand new Personal Data Protection Act in Sri Lanka, enacted in 2022 by Act number 9, marks a significant advancement in the country's legal framework regarding data privacy. This law aims to safeguard personal data while establishing clear guidance for its collection, processing, and storage. The medical profession, which handles sensitive personal information, is particularly impacted by these regulations. What are the key provisions under our brand new Act? Consent and data subject rights are very important under the Act. The Personal Data Protection Act emphasizes the importance of obtaining explicit permission from individuals before collecting their personal data. Patients have the right to access, rectify, and request the deletion of their data, which is crucial in healthcare settings. The law mandates that personal data must be processed fairly, lawfully, and transparently. Data minimization is emphasized, meaning healthcare providers should only collect data necessary for specific purposes. Medical data is classified as sensitive personal data, requiring additional safeguards. The law restricts processing such information unless specific conditions are met, such as necessity for medical purposes or with explicit consent. Healthcare institutions are required to appoint data protection officers, this is mandatory under this Act, to oversee compliance with the Personal Data Protection Act, ensuring proper management of patient data and adherence to privacy standards. This Act mandates that organizations report data breaches to the Data Protection Authority and affected individuals promptly, enhancing accountability and transparency. So let's see what are the implications for the medical profession under this law. Healthcare providers must navigate the complexities of the Personal Data Protection Act, ensuring that their data handling practices align with legal requirements. This includes updating policies, training staff, and implementing robust data security measures. By adhering to the Act, medical professionals can enhance patient trust. Patients are more likely to share sensitive information with providers who demonstrate a commitment to protecting their privacy. With the rise of telemedicine, the Act affects how healthcare providers collect and manage data remotely. Compliance with data protection standards is essential, particularly when handling patient information online. Non-compliance with the Act can lead to significant legal repercussions and financial penalties. Medical institutions must invest in compliance strategies to mitigate these risks. As far as this development of this law is concerned, the personal data protection law in Sri Lanka represents a crucial step towards enhancing data privacy and security, particularly in the medical field. By prioritizing patient rights and establishing clear guidelines for data management, the Act seeks to foster a culture of trust and accountability in healthcare. As the medical profession adapts to these regulations, ongoing education and vigilance will be essential to navigate the evolving landscape of data protection in healthcare. Under the development of technology, next area that we have to regularize is medical device regulation. Regulatory bodies such as the United States Food and Drug Administration and the Medicines and Healthcare Products Regulatory Agency in the United Kingdom oversee the approval of medical devices, ensuring they meet safety and efficacy standards before being used in clinical settings. Continuous monitoring of medical devices after approval is essential to identify any adverse effects or safety issues that may arise during actual use. Licensing and credentiality regarding telemedicine and regulations must address the licensing of healthcare providers who offers them telemedicine services, ensuring they meet the necessary qualifications and standards, regardless of where the patient is located. Clear guidelines on reimbursement for telehealth services are needed to encourage adoption while ensuring that providers are compensated fairly for their services. Under development of artificial intelligence, we call this as machine learning mechanism as well, that AI algorithms used in diagnostic and treatment decisions must undergo rigorous validation to ensure their accuracy and reliability. Regulatory frameworks must evolve to evaluate and certify these technologies. Regulations should require that AI systems provide transparent reasoning for their recommendations, allowing healthcare professionals to understand and trust the technology. Interoperability standards are also important under the development of AI era. Regulations should promote interoperability among different electronic health record systems to ensure seamless data exchange, which is vital for coordinated patient care. Regulations can encourage software developers to prioritize user experience, minimize clinician burnout, and ensure that technology enhances rather than hinders patient care. The rapid pace of technological advancement often outstrips regulatory processes, creating a gap where new technologies may be used without adequate oversight. Regulators must strike a balance between fostering innovation and ensuring patient safety. Over-regulation can stifle advancement, while under-regulation may lead to safety risks. Healthcare technology often crosses borders, leading to challenges in harmonizing regulations across different countries and regions. This inconsistency can complicate compliance for global companies. As technology increasing influence healthcare decisions, ethical considerations regarding algorithmic bias, patient consent, and the role of technology in clinical decision making must be addressed. So considering all these matters, we can conclude in this manner. The regulating technology in healthcare is a complex but essential task that requires collaboration among regulators, healthcare providers, technology developers, and patients. Effective regulation should promote innovation while ensuring patient safety, privacy, and ethical standards. As technology continues to evolve, regulatory frameworks must adapt to address emerging challenges, fostering a healthcare environment that leverage technology to improve patient outcomes while safeguarding public trust. At the moment in Sri Lanka, there are 6 pieces of legislation relevant to the ICT sector, starting from Computer Crime Act in 2006, the Evidence Special Provisions Act, to give facilities to accommodate electronic evidence before court, Act number 14 of 1995. And then we have Electronic Transactions Act. It's important to maintain electronic records, electronic documents, and in any communication in electronic form in Sri Lanka. We brought an amendment to this act after ratifying UN Convention on International Electronic Contracts. In the meantime, we have Personal Data Protection Act, just now I addressed on that, Act number 9 of 2022. And recently, our lawmakers introduced Online Safety Act, number 9 of 2024. Very soon, we will get Cyber Security Act. As citizens, we may be medical professionals, legal professionals, or any other professions. We are citizens of this country. So we are subject to these laws, brand new laws, because as I indicated to you earlier, technology is developing. It's relevant to all these professions. In the meantime, legal impact on these new technologies is also important for the betterment of our life. Thank you very much.
Thank you very much, Dr. Sunil Aberatna, for highlighting the intricate web of challenges and opportunities which the regulators face in harnessing the potential technology while safeguarding patient safety. Now it's open for discussion. If anybody has any questions, can ask. If not, can I ask Professor Anuja Fernando, how do economic pressures like and healthcare resource allocation, like in a third world settings where we have a lot of issues with resource allocations, and how can it create ethical challenges for clinicians and policymakers?
I didn't quite understand.
In the third world setup where we have a lot of challenges with resource settings, where resource allocations are not adequate, treatment expensive, so how can ethical challenges can have an impact on clinicians and policymakers?
I suppose you just you have to manage with what you. You will have to, I suppose, manage with what you have, and what we are actually doing is getting the patient to spend sometimes, isn't it? If we can't afford to spend for the drugs, if the government can't afford, we get the patient sometimes to buy various equipment or drugs. So I suppose that's all right if the patient can afford, but if not, you could have a sort of a fund. I think we have that also, President's Fund or something like that, where you can get money. Otherwise, there can be a problem, I mean, when you have to spend for, say, some rare diseases with expensive drugs. That's a sort of the time that you go to the President's Fund, I suppose. I think you can appeal for donors also. There must be quite a lot of rich donors who will be willing to give money. Right?
Thank you. Next, Professor Dame. How can regulators balance the role of enforcers of standards while being perceived as partners in improving healthcare qualities and safety?
So how can we maintain standards while there's difficulty maintaining? Right, yeah. I mean, maintaining standards is, the standards are very broad, and we make sure that everybody has bought into them. That includes the profession and the public, all have been fully worked through. And we need to make sure that they are manageable. We've come back down to resources again here. Within every country, there is a resource envelope through which healthcare can be delivered. And I think that we have to recognise that and understand that, not necessarily make allowances for it, but make sure that we recognise that when it comes to the compassionate way in which we deal with both the public and with the profession who we're regulating.
To Dr. Sunil Aberatna, should there be a one-size-fits-all approach to regulating health technology, or there should be a regulation which is risk-based, adapted or to a specific technology?
Technology is always risky. There is no doubt about that. Today's technology is not the technology tomorrow. We are living in such an environment. So therefore, that introducing the proper regulations, it doesn't mean that regulators want to restrict our professional affairs. These regulations are there to build up goodwill between patients and medical professionals. So therefore, when we follow these regulations, we can see the risk-free, we can carry risk-free professions. That is the important thing. These regulations are there to safeguard this profession without any delay. This is what we can see. There's a delay of introducing regulations, not only in the medical sector, but other sectors also same, even in my sector as well. So therefore, it's a time to introduce the required regulation without any delay to face tomorrow, this situation.
Thank you. Just final one, I think, before we wind up. So what do you think about the Online Safety Act? Is it too harsh on the people who are going to implement it?
The problem is we drafted this Online Safety Act following some piece of legislation available in European countries. First of all, we must understand socio-economic, cultural and political situation is quite different in Sri Lanka to European Union countries. We can't just bring the carbon copy of these acts to Sri Lanka. We have to adjust everything according to our cultural and social issues. Online Safety Act is good. The reason is we are using all devices. We bring these devices from other countries. In Sri Lanka, we only assemble. We are not manufacturers. And we use internet. What is internet? We don't use the Sri Lankan internet, or we don't use Indian internet or Pakistan internet. The internet is internet. If we use this common internet, and if we use common device, why can't we follow the legal provisions of other countries? The issue was drafting of this act. Even I'm the chairman of ICT Lawyers Guild of Sri Lanka. We also filed a case against Online Safety Bill. We challenged the appointment of commissioners. Earlier, commissioners were to appoint by His Excellency, and removal also from His Excellency. Only the commission can prosecute a case. Now you can understand biasness of this act. So after challenging, the Supreme Court changed this provision. Now it must go before Constitutional Council. Problem is, the people who come to positions, they must play a neutral role. This is the attitude of people. It is not the fault of the act. So we have to go a long way. Considering new offences specified under third part of Online Safety Act, this is for the safety of the people in this country. If other countries can maintain the same offences, why can't Sri Lankans use it?
Thank you very much. I'd like to thank all three panelists or eminent panelists for the discussion. Thank you very much.
And we would now like to invite the moderator to present tokens of appreciation to our esteemed panelists. And it is my honor to invite the speakers to please come forward and graciously accept this token of our heartfelt appreciation. Professor Anoja Fernando. Professor Dame Carrie McEwan. and Dr. Sunil Aberatna. Following this, I would like to invite Professor Manori Gamage, Dean of the Faculty of Medical Sciences, University of Sri Jayawardenepura, and Council Member of the Sri Lanka Medical Council, to kindly present a memento to the moderator, Dr. Suresh Shanmuganathan, as a gesture of gratitude for his leadership and moderation of this panel discussion. Thank you to our distinguished dignitaries. You may please take your seats. And ladies and gentlemen, we shall now adjourn for the lunch break, which will be served at the Sapphire Banquet Hall. And we kindly request you all to please return to your seats by 1 p.m. as the next session will commence promptly. Please be mindful that we hope to start sharp at 1 p.m. Thank you.
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern, user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online, and the registrants are able to get their services done wherever they are living without making physical visit to the Medical Council in Colombo. We have modernized services are now provided online and payments are made online so that the people who need their services can get their services from wherever they, rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office.
Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern, user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online, and the registrants are able to get their services done wherever they are living without making physical visit to the Medical Council in Colombo. We have modernized our service provision in great way so that the most of the services are now provided online and payments are made online so that the people who need their services can get their services from wherever they, rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office.
Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our 100-year-old medical ordinance, even with its 32 amendments. For example, there is no lay representation on the council. The current ordinance addresses the important area of medical conduct through only 12 brief statements, and there is hardly any mention regarding patients' rights. The present council's vision for the future was to rectify these shortcomings by means of drafting a new medical act. An act focused primarily on public safety and healthcare, and one that would improve trust in the regulator. The new draft medical act has revised the manner in which the council would be constituted, with, for the first time, inclusion of non-medical members, and having a balance of both appointed and elected members. Attempts have also been made to rectify the shortcomings in the old ordinance, with special attention being paid to patients' rights, professional ethics and fitness to practice, the regulation of advertising, quality assurance and setting standards in medical, dental and allied health education, dealing with complaints, and interim prohibition orders for dealing with unregistered individuals who are commonly known as quacks, which has been a lingering national problem. The draft act, which was unanimously approved by the council, is now at the stage of obtaining the necessary approvals before it can be formally enacted.
Years of existence is a very important milestone in any organization. In organizing an event to celebrate such an event is not an easy task. This task was made much easier by a very eminent and a very cooperative committee and all the other staff members of the Sri Lanka Medical Council. The team chosen for this event was patient safety and quality health care for all. The role played by the Sri Lanka Medical Council in providing quality health care for the whole country is celebrated in this event. The academic sessions, which will take place in the morning, will concentrate on various aspects of regulation of medical services in Sri Lanka and globally. And the evening event will celebrate the 100 years of existence with the participation of many dignitaries.
The Sri Lanka Medical Council is a unique organization established 100 years ago. It has evolved into an effective regulator of both training and practice of medical, dental, and allied health professionals in Sri Lanka. The professionals that we regulate now work across the world, and therefore, as we celebrate our centenary, we are looking forward to collaborating strongly with other global regulators so that our regulatory standards are par excellence and second to none.
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern, user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online and the registrants are able to get their services done wherever they are living without making physical visit to the medical council in Colombo. We have modernized our service provision in great way so that the most of the services are now provided online and payments are made online so that the people who need their services can get their services from wherever they, rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office. Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our 100-year-old medical ordinance, even with its 32 amendments. For example, there is no lay representation on the council. The current ordinance addresses the important area of medical conduct through only 12 brief statements, and there is hardly any mention regarding patients' rights. The present council's vision for the future was to rectify these shortcomings by means of drafting a new medical act, an act focused primarily on public. Attempts have also
Sri Lanka and globally. And the evening event will celebrate the 100 years of existence with the participation of many dignitaries.
The Sri Lanka Medical Council is a unique organization established 100 years ago. It has evolved into an effective regulator of both training and practice of medical, dental, and allied health professionals in Sri Lanka. The professionals that we regulate now work across the world, and therefore, as we celebrate our centenary, we are looking forward to collaborating strongly with other global regulators so that our regulatory standards are par excellence and second to none.
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online, and the registrants are able to get their services done wherever they are living without making physical visit to the Medical Council in Colombo. We have modernized our service provision in great way so that the most of the services are now provided online and payments are made online, so that the people who need their services can get their services from wherever they, rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office. Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our 100-year-old medical ordinance, even with its 32 amendments. For example, there is no lay representation on the Council. The current ordinance addresses the important area of medical conduct through only 12 brief statements, and there is hardly any mention regarding patients' rights. The present Council's vision for the future was to rectify these shortcomings by means of drafting a new medical act. An act focused primarily on public safety and healthcare, and one that would improve trust in the regulator. The new draft medical act has revised the manner in which the Council would be constituted, with, for the first time, inclusion of non-medical members, and having a balance of both appointed and elected members. Attempts have also been made to rectify the shortcomings in the old ordinance, with special attention being paid to patients' rights, professional ethics and fitness to practice, the regulation of advertising, quality assurance and setting standards in medical, dental and allied health education, dealing with complaints, and interim prohibition orders for dealing with unregistered individuals who are commonly known as quacks, which has been a lingering national problem. The draft act, which was unanimously approved by the Council, is now at the stage of obtaining the necessary approvals before it can be formally enacted.
Years of existence is a very important milestone in any organization. In organizing an event to celebrate such an event is not an easy task. This task was made much easier by a very eminent and a very cooperative committee and all the other staff members of the Sri Lanka Medical Council. The team chosen for this event was patient safety and quality health care for all. The role played by the Sri Lanka Medical Council in providing quality health care for the whole country is celebrated in this event. The academic sessions, which will take place in the morning, will concentrate on various aspects of regulation of medical services in Sri Lanka and globally. And the evening event will celebrate the 100 years of existence with the participation of many dignitaries.
The Sri Lanka Medical Council is a unique organization. Established 100 years ago, it has evolved into an effective regulator of both training and practice of medical, dental, and allied health professionals in Sri Lanka. The professionals that we regulate now work across the world, and therefore, as we celebrate our centenary, we are looking forward to collaborating strongly with other global regulators so that our regulatory standards are par excellence and second to none.
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern, user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online, and the registrants are able to get their services done wherever they are living without making physical visit to the Medical Council in Colombo. We have modernized our service provision in great way so that the most of the services are now provided online and payments are made online so that the people who need their services can get their services from wherever they rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office. Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our 100-year-old medical ordinance, even with its 32 amendments. For example, there is no lay representation on the council. The current ordinance addresses the important area of medical conduct through only 12 brief statements, and there is hardly any mention regarding patients' rights. The present council's vision for the future was to rectify these shortcomings by means of drafting a new medical act, an act focused primarily on public safety and healthcare, and one that would improve trust in the regulator. The new draft medical act has revised the manner in which the council would be constituted, with, for the first time, inclusion of non-medical members and having a balance of both appointed and elected members. Attempts have also been made to rectify the shortcomings in the old ordinance, with special attention being paid to patients' rights, professional ethics and fitness to practice, the regulation of advertising, quality assurance and setting standards in medical, dental and allied health education, dealing with complaints, and interim prohibition orders for dealing with unregistered individuals who are commonly known as quacks, which has been a lingering national problem. The draft act, which was unanimously approved by the Council, is now at the stage of obtaining the necessary approvals before it can be formally enacted.
Years of existence is a very important milestone in any organization. In organizing an event to celebrate such an event is not an easy task. This task was made much easier by a very eminent and a very cooperative committee and all the other staff members of the Sri Lanka Medical Council. The team chosen for this event was patient safety and quality health care for all. The role played by the Sri Lanka Medical Council in providing quality health care for the whole country is celebrated in this event. The academic sessions, which will take place in the morning, will concentrate on various aspects of regulation of medical services in Sri Lanka and globally. And the evening event will celebrate the 100 years of existence with the participation of many dignitaries.
The Sri Lanka Medical Council is a unique organization established 100 years ago. It has evolved into an effective regulator of both training and practice of medical, dental, and allied health professionals in Sri Lanka. The professionals that we regulate now work across the world, and therefore, as we celebrate our centenary, we are looking forward to collaborating strongly with other global regulators so that our regulatory standards are par excellence and second to none.
Sri Lanka Medical Council has changed from a conventional medical regulatory authority into a modern, user-friendly, customer-friendly regulatory authority that meets the expectations of the people in the 21st century. We have a well-trained staff who are willing to help the customers as and when required, and they are willing to go extra miles if they need additional help or any other assistance. The Council has modernized their service provision modes where the registration and other services are now processed online and payments are made online, and the registrants are able to get their services done wherever they are living without making physical visit to the Medical Council in Colombo. We have modernized our service provision in great way so that the most of the services are now provided online and payments are made online so that the people who need their services can get their services from wherever they, rather than coming to the Colombo or making physical visits to the Sri Lanka Medical Council office. Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. The same claim cannot, however, be made regarding our 100-year-old medical ordinance, even with its 32 amendments. For example, there is no lay representation on the council. The current ordinance addresses the important area of medical conduct through only 12 brief statements, and there is hardly any mention regarding patients' rights. The present Council's vision for the future was to rectify these shortcomings by means of drafting a new medical act. An act focused primarily on public safety and healthcare, and one that would improve trust in the regulator. The new draft Medical Act has revised the manner in which the Council would be constituted, with, for the first time, inclusion of non-medical members, and having a balance of both appointed and elected members. Attempts have also been made to rectify the shortcomings in the old ordinance, with special attention being paid to patients' rights, professional ethics and fitness to practice, the regulation of advertising, quality assurance and setting standards in medical, dental and allied health education, dealing with complaints, and interim prohibition orders for dealing with unregistered individuals who are commonly known as quacks, which has been a lingering national problem. The draft act, which was unanimously approved by the Council, is now at the stage of obtaining the necessary approvals before it can be formally enacted.
Ladies and gentlemen, I hope you had an enjoyable lunch and are feeling refreshed. We are now ready to convene to continue our discussions, and we appreciate your punctuality and enthusiasm, and we look forward to the engaging sessions ahead. Please take your seats, ladies and gentlemen, as we move on to the third plenary session titled The Future of Medical Education, Aligning with Global Standards. And it is my distinct honor to invite Dr. Chandika Epitakaduwa, who is a consultant histopathologist currently serving at the base hospital Caravanella. In addition, he extends his expertise to histopathology services at the Colombo East Base Hospital, the National Institute of Infectious Diseases, and the National Institute of Mental Health. Dr. Epitakaduwa has been actively engaged in medical education and currently holds the position as the Vice President of the Sri Lanka Medical Council. May I now respectfully invite Dr. Chandika Epitakaduwa to the stage to assume his role as chair of this plenary session. Please join me in offering him a warm and appreciative welcome.
Thank you very much. Today we celebrate 100 years of existence. This moment is the best time to look forward. So let me introduce our first resource person. Professor Dujipa D. Samarasekara is the head of Center for Medical Education at the Yong Lu Lin School of Medicine, National University of Singapore, and an adjunct professor of medical education at the School of Medicine and Dentistry, Griffith University, Australia. Professor Samarasekara currently serves as the academic lead for quality improvement and the exam audit lead across undergraduate and postgraduate and residency programs in medicine and nursing. Today, he will deliver his speech on integrating technology into medical curricula. Over to you, sir.
Thank you very much, Dr. Epitakaduwa. Well, I feel very honored and privileged to be here, and I want to thank Professor Vajira Disanayake, Professor Ranil Fernando, and also the SLMC organizing committee. I say that this is a true honor and a privilege because I can remember I got my first practice certificate from the Sri Lanka Medical Council right after my internship. And I can still remember after getting the signatures from Dr. Kodita Selleheva and then rushing to the Sri Lanka Medical Council to get the earliest registration number. Right? That was the thing for all of us as young doctors. And I can still remember my number 12,350. So I'm the 12,350th doctor registered with the Sri Lanka Medical Council. I'm going to restrict my focus on the technology. And also, I hope that we'll all finish in time so that there's enough time for some discussions. So bear with me if I rush through some areas. And also, I'll try to kind of summarize during the end and also during our conversations. So just like we are celebrating 100 years, just on Thursday, the School of Medicine at National University of Singapore, we celebrated 120th year. So it's a twin celebration for me. Again, I feel very privileged celebrating the 120th year and also the 100th year celebrations at SLMC. I'm mostly 3 days of my work week I spend at the Center for Medical Education, where we focus on developing international and global standards, not only to Singapore, but also to the region and also globally. I'm part of this wonderful center, and I'm also very thankful to them for making sure that everything works well back in Singapore while I'm here. This is something that I need to share as part of my organizational accountability, that whatever I share here are my own personal things unless represented or referenced. My focus today will be to share with you and evaluate the role of advanced technologies in medical training, both undergraduate, residency, specialist, and continuous professional development. Also, how do we apply these evidence-based strategies for adaptation, and then discuss some challenges and way forward. And I'll bring the School of Medicine, the National University of Singapore School of Medicine strategies for two reasons. Firstly, I feel that it is important that I share what I have been involved in and what I have been operationally doing, because I don't want to share conceptual or abstract things or find from different places. So whatever I share are things that I have personally been involved or being part of a group that has been employing these technologies. Secondly, I'm sharing this not to wow you or to mesmerize with you or go with the understanding, oh, that we can't do because we don't have the money or whatever the resources. No. This is a journey that the medical school has taken from absolutely just like no resources to what we have now. So I want you to see this as a journey. And we took this decision in 2010, about 15 years ago, that we want to move to digitalized training for both the undergraduate, specialist, and also as part of our CME processes. Right. So I want to start off with this quick report from the World Economic Forum, because I think right now most of us Sri Lankans are very much engrossed in this World Economic Forum interviews. So I thought that this interview was really good, and it is available on their website. You can download the report, where it very specifically say that by 2030, not very long, another 5 years' time, the largest technology company will be based on education and health, right? And that is not far from the truth. Right, there are three key principles when we apply technology into medical and health professions training. First of all, it is pedagogy before technology. None of us should go with novelty or availability. And I do know that in some settings where I have seen, and I've been part of some accreditation teams also in the region and outside, just because that World Bank gives a lot of money, or from Asian Development Bank you get some money, you set up a quick simulation center. And then that simulation center is really a burden, because you have to maintain that. Or, advanced technologies, you buy the latest Harvey or, some simulator, and then you are stuck with it because, it gets broken or whatever, because it requires a lot of maintenance, and then that money is wasted, right? So how do we integrate this into technology, into education and training? Secondly, are we using the best evidence approaches or best practices in integrating and evaluating the ones that we have applied? And there's a demonstrable educational value. And thirdly, I think this is critical. Most of us, we did not develop with technology like our children or our students or our residents. So there needs to be a very well-planned faculty support and also faculty development. And then finally, the ethical consideration, the policy and guidance. These must also be inbuilt. I think these are the 4 core principles for adopting technology in any setting. Right. Now, I'm now going to bring our own experience at the School of Medicine, which anchors both undergraduate and specialist training. So we have a very comprehensive system based on those 4 principles. And in this quick slide, I try to display how all these elements actually play with one another. But I'll take you through a typical day of a student or a resident, a specialist resident going through training. So they wake up in the morning, they look at the schedule, and that is all in their tablet or their phone, etc. You can look at what the week looks like or what the day really looks like. And then, of course, there will be what we call online learning, right? They need to go through certain things because in the medical school and our nursing schools, all three medical schools as nursing schools, we don't have lectures anymore. These are all interactive sessions. There are no lectures like this. We don't give lectures anymore, right? So you have to get prepared. And this preparation time is timetable. They don't have to do that in the night or during their spare time, but it is scheduled into the timetable, right? So they can come together at school, and there are places available for them to come together and learn together, right? This collaborative learning. It is timetable. And then, of course, you have these, what we call interactive sessions. It's a flipped classroom model, right? In the lecture, you discuss cases, you discuss problems, you discuss issues, and based on what they have learned earlier, and then you clarify. And there are various different modalities you use, like team-based learning and something what we call the collaborative learning cases. And this is then linked to actual practical session, right? So using classroom response systems. And it is linked to what we call an active learning session, either in the simulation center or in the clinical ward, where they have to actually go and practice what they have learned. So it is almost aligned. And then afterwards, the students have the opportunity through the teams, that we have dedicated teams, what we call the Microsoft Teams, where they can clarify things, not only with their immediate clinical group, but with the entire batch or the cohort as well. And this is monitored back-end by a faculty member, and also very recently, which I will show if I have time, through AI, which they will be getting very prompt feedback. We have now a medical school chatbot, which we have programmed all our anatomy, physiology, biochemistry, pathology, microbiology, surgery, medicine, the entire curriculum. So they can use that as their personal tutor. Right, so this is just to show you very quickly in a short video, what are some of the resources that the students enjoy in their learning. This is our anatomy. They are learning anatomy and disaster management and active clinical conditions. Okay, I'll move forward because of time. So this is again a fully equipped simulation center where they have to get themselves, there's a exam. Once they get through, only they are allowed into patient wards and other places. And one of the important things I want to share is that here the learning is collaborative. Our medical students and nursing students and pharmacy students learn together. Right? So you can see here these two photographs. The nursing students and medical students are learning on different procedural skills that they're supposed to learn. For the faculty members also, there's plenty of resources available for them to use. And remember, this is again 15 years of slowly developing it, not overnight, right? From absolutely nothing, just the LMS to what we have now, right? So one of the things like our collaborative learning cases, these are now have been highlighted by Times Higher Education as one of the very innovative ways of training medical and nursing students. Not only the learning, we are also using AI and technology in designing of our assessments, both for undergraduate specialist training programs, right? Specialist training exams, high-stake exams. So from item generation to proctoring, automated scoring, analytics, psychometric analysis, which we have now slowly building and I'm very grateful to my colleague Gominda for helping us in this, and also developing feedback, immediate feedback for students and trainees as well. So this is a comprehensive system that we are also developing, incorporating technology to assessments. And my colleague, Gillian Yo, who is now a part of the Center for Medical Education, she's a pharmacist by training. She's now pioneering a task force to bring everything together. So student performance assessments, the feedback, the curricular performance with the national standards and international benchmark standards, and then putting that into accreditation teams, what they have shared, and then to generate using AI, how we can actually see what are the areas that are working well in the curriculum, what are the areas that needs enhancement, what are the gaps. So now with this, we have made our systems so fast that we get very real-time accurate data. And the quality assurance team, which I'm part of, we get very real accurate data on how the processes and systems are working. Now that's the advantage of having incorporating AI, going beyond just the teaching and learning. And all this is done through the oversight committee, and then of course there's support for the entire faculty to create more, think beyond the box, right? And then, of course, specific training and micro-credentialing. So we have our NUS Artificial Intelligence Institute, and then from the hospital, the head of Artificial Intelligence Office at NUHS, that's our Academic Health Center, where they have micro-credential programs, from micro-credential certificates, etc., all the way to a master's in MSc in biomedical informatics, right? So faculty is very well supported, and they're trained as well. The earlier, I don't have time, so I'll just take one more minute. I think this is also important, because earlier the other plenary speaker shared about the importance of policy and security with PDPA coming on board. So because of that, the university has invested in our own generative AI. The beauty of this is that our data is safe. It's not going into a cloud. So I myself have my own generative AI. So you can see that this is my GPT. I can upload any documents, completely secure. Student data, faculty performance data. It is within the secure cloud. So PDPA compliant, right? So it actually helps me. I can put in all as part of the head of quality assurance, I can put in all the faculty performance, the modules that they are doing, and the students, how the students are doing, and ask, can you share with me which hospitals are training our students properly and which are the ones that are lacking? And immediately I get the information, which I can start a conversation. That may not be 100% accurate, but it actually gives me time and my team members to start these conversations with the associate deans of those hospitals and to see what we can do to help improve as well. So this is a secure environment where the data is secured and it's PDPA compliant. And the policies are also developed aligned with the national policies. So our university itself, we have our policy for AI for teaching and learning, AI for use of AI in assessments, and then of course, how do we evaluate whether the AI is really giving us the proper data, right? We are also aligned to the International Advisory Committee, which we are part of as the Asia Pacific Medical Education Network. And I'm happy to say that we just managed to get one of our Sri Lankan colleagues to be part of this, Professor Katulanda from University of Colombo. So he is also part of this panel now in the future, starting from next month. So there are advantages and challenges. I will not go into that. We can discuss that during our presentations. But I think the way forward is to start with scalable, low-cost AI application. That is our experience. In 2012, 2010, we never had all these beautiful stuff. But we started with low, scalable, like our LMS, our own the learning management system, and we slowly build it around that based on those 4 principles that I mentioned earlier, right? And I think the rest you can read through, but it is important that we start small, and then, of course, we focus on how we build. Just last slide, we are not only just doing things, but we are also evaluating the impact. So these are all projects, scholarly projects, and we also share as part of our scholarship in how we are doing it, what's the impact, and how it is going to benefit a larger community. So with that, I just want to summarize that definitely use of AI and other technologies meaningfully will enhance your training in medical students as well as specialist trainees. It helps to bridge gaps, also help to provide feedback, but also need to focus on how to train your faculty. Ethical and regulatory framework is really important, and we need to focus on that. But as I always say, think big, act small, start small, but act now. With that, thank you very much.
Thank you, Professor Samarasekara. Our next speaker is going to be Professor Madhav Chandratilaka. He is the Dean of the Faculty of Medicine, University of Kelaniya, Sri Lanka, and Chair Professor of Medical Education. He is both nationally and internationally recognized for his contribution to curriculum development, assessment, and professionalism in health professions education. Today, he will deliver his speech on addressing gaps in healthcare workforce training. Over to you.
Thank you. Thank you very much for inviting me for this speech, and I consider that as a privilege to be a part of the centenary celebrations of the Sri Lanka Medical Council. So during these 15 minutes, I'm sharing a few ideas about addressing the gaps in healthcare workforce training in Sri Lanka. Basically, we talk about numbers, how many doctors are there, how many nurses are there, how many healthcare professionals are there, and what is the ratio of patient to doctors, patient to other healthcare professions, how many have migrated, how many are staying behind. And all these numbers are important issues when we talk about healthcare workforce. But when we talk about healthcare training gaps, it is more about quality than quantity, because if we define what is healthcare training gaps are, it's the mismatch or the misalignment between the competencies, the knowledge, skills, and attitude imparted through educational programs and the actual requirement in delivering the healthcare. So my presentation will be largely focused on improving the quality of educational programs and improving the quality of the product. There are so many dimensions to training gaps. However, I've chosen a few key aspects, dimensions, setting training goals, curricula, programs, and the personal attitudes of stakeholders, and the role of regulatory and governing bodies. Now, if we are to deliver a program, we need to know the goals of that program. To know about the goals, we should know what is expected from the product. For example, what are the expectations with regard to doctors, nurses, other healthcare professionals. We cannot define these roles if we don't know about the vision and the strategic plan for healthcare development or healthcare system development for the next 25 years, 10 years, or 5 years. So the first thing would be that we need to have a consistent, solid plan. Of course, the strategic plans and vision can be changed from time to time based on the changes that happen in many contexts. But we need to have some sort of a direction, guidance that is agreed by everybody to define our expectations. If we can know our expectations from different categories of healthcare workers, then we know what should be the outcomes, what are the goals of the program that we are developing. I think this is a gap that we see in the current context. Secondly, we actually introduce new programs. We change curricula. we focus on buildings, we focus on facilities, and we think that if the facilities are there, if the buildings are there, we can make the change or we can strengthen the workforce. However, I propose, yes, they are important. There's no doubt about it, but more important is focusing on people. What is more important is, yes, the documents, the curricula, the prospectus, the changes, the revisions, they are important, but how to change the perspective of people, of the stakeholders. I think that is a gap that we see. Our focus, our change is directed towards physical components, but not the live components of the wheel. For example, in medicine, we change curricula, we have curricula, and in those curricula, as Professor Evans just mentioned a few hours ago, are we considering soft skills, professionalism, attitudes, and various aspects as important as anatomy, physiology, and biochemistry? Is it only about imparting knowledge and skills? So we are focusing more on imparting knowledge, what people can do rather than what people should know rather than what people can know, should know. So the focus need to be changed. And on the other hand, one example is a continuing medical education program, continuing professional development program. Do we have one? Yes, there is a one, and it's very rudimentary. So then revalidation or reaccreditation of people as professionals. So we have started processes, but we have not gone far with it. So that's one area that I see as a gap. So if you consider other healthcare professionals, for example, there's a huge need of professionalization of professions. And that need to be done to strengthen the workforce. For that, I think producing healthcare professionals as graduate from universities would be a good thing, because that is the trend in the rest of the world. Yes, we have issues, we have challenges with large numbers required by the healthcare system. We might not be able to produce through universities, but there should be a weaning off strategy. So the educational responsibilities is given to the universities, and the CPD, or the continuing professional development, is taken over by the ministry or the service providers. So that is something that we can think of. On the other hand, they don't have structured and formal postgraduate program. I think it's a part of professionalization, and we need to think about that aspect as well. Also, a continuing professional development as well as revalidation. So those are gaps that we can see with regard to programs and curricula. And again, about the personal attitude. For example, what do we think about the mid-level qualifications that we are going to offer to medical professionals? Within the profession, there are reservations. And also, there are issues about giving opportunities to other healthcare professionals, other categories of allied healthcare workers. So then we need to think about all these things, and if we don't have the right attitude, right perspective about all those things, that can be a gap. The regulatory and governing bodies, the role of the regulatory and governing bodies in bridging the gap or in addressing the gaps in training workforces. We know that there's no proper coordination among the Sri Lanka Medical Council or other regulatory body, health ministry, the universities, and service providers. And there's no there's no collaborative effort about what need to be done. So I think that collaboration needs to be established soon. That's a gap. And most of the time, these entities actually work in silos. They develop their policies, they try to share it, and it is rejected. The other party is coming up with another one, and it's all about developing policies but not implementing a common policy. So there should be a collaboration between different stakeholders, and the public is an important part of it. Not only the regulatory bodies, the ministry, the professional bodies, the trade unions, and universities, and the public should get together, and in a common forum, we need to develop a common strategic approach to train our workforce. Otherwise, it remains unfulfilled task. So what do we need to do in addressing these gaps? We need a vision. And it should be a consistent vision. I mean, constant or something that will not change for a period of time. And that vision need to be backed up very well by strategy, a strategy that can be implemented, that can be practical. Of course, as I said, the vision, the strategy can be modified, can be revised, depending on the circumstances. However, we need to have that sort of approach. And we need to be flexible. We should not be very dogmatic and narrow focus. Things are changing, and things are changing all over the place. And in Sri Lanka, our context might be different. Depending on the changing circumstances, we need to change. So is there a flexibility to strengthen the workforce of our health system? We need to be creative. We can come up with solutions that are unique. We might not have seen it for the last 100 years. That does not mean the created one is not going to work. On the other hand, we can be very innovative. And there are so many issues. For example, the internship issue that we are going to face. Can we have a very innovative approach to that? What is the basic requirement? Is it the exposure or the training, or is it the duration? Is it the way that I did it? So we need to think about all these aspects. And we should not be very scared about technology, incorporating technology. Dujipa just mentioned about how practically, how easily they have used technology in finding answers to many challenges that they have faced. And it's not about money, it's not about resources, it's about our attitude towards using technology. And the mutual respect. I think we are a multidisciplinary team, the teams are working together, and our ultimate goal is to provide the optimal care for our patients. So in that case, we need to have mutual respect towards our colleagues, as well as between different disciplines. Human resources, I put it within brackets because it is not necessary to have the numbers. I was just about to ask a question from Professor McCavin about whether high numbers necessarily produce high quality healthcare. I don't believe so. I think the human resources can be improved if we use the right strategies. And with the numbers that we have, we will be able to achieve a lot. May not be 100%, but a lot if we have the right strategy to do so. There are some success stories. I think Singapore, I went through some of the success stories, and I thought Singapore is the best because they have developed a collaborative team which involved the Ministry of Health, Ministry of Education, Health Manpower Development Plan, Singapore Medical Council, and all the universities involved in healthcare professions study programs. So they got together and they made a plan and they have executed it, and I thought it has given them, I read and I thought that it's a nice model which has delivered what they wanted. And also, the UK. They have a national plan. I think previously they had a plan and they have revised it in 2021. Again, a collaborative effort to improve and strengthen their healthcare workforce. Another example is coming from Thailand. It's quite old, but they have produced results through this collaborative, consistent planning and actions. Rwanda, for example, it has developed a plan for 10 years in 2013, and the results are there for them. And we know that how Rwanda has come up with their development, especially in the healthcare. Ethiopia. We took Ethiopia as an example for something different in the past, but we are now learning from Ethiopia. So they have implemented the plan and the results are available. So basically what they have done is putting a collaborative effort. All stakeholders involved in workforce training, healthcare workforce training, have got together and they have developed the plan and they have executed it. India, our neighboring country, is one of them. But unfortunately, I heard that there's issue with this. I just got a news saying that there's a shattering of these collaborations, but these are challenges that we face. So they have implemented something and now they have got problems because of people. people don't change their attitude, their behaviors. Because of that, it has collapsed. Dujipa just mentioned to me that there's a news today that there's an issue, challenge in India. But most of these are actually success stories. So we have spent 200 years and we have achieved a lot of successes. However, I personally feel that if we continue the practices and attitudes and things that we did in the last 100 years for the next 100 years, we will be 200 years behind. Thank you.
Thank you, Professor Chantilaka. Our next speaker is going to be Professor Gominda Ponnamperuma. He is the Professor of Medical Education at the Faculty of Medicine, University of Colombo, Sri Lanka, and Head Accreditation Unit of Sri Lanka Medical Council. He is a postgraduate tutor, examiner, and resource material developer for national and international courses. Today, he will deliver his speech on should we revisit entry criteria for medical education. Over to you.
Thank you. Thank you very much for inviting me to give this important speech, which probably we should think of when we think of the next 100 years. Because we are practicing method of or certain criteria for entry, whether they are applicable to the next 100 years and how much of it is acceptable for the next 100 years or let's say next 20 years, or should we revisit them is the question that I will explore, but perhaps I will not answer it, but I will give you some ideas for you to think and then we can make an informed decision after further deliberation. So to begin with, I will give some modern principles or concepts with regard to admission and their consequences. So the first concept is admission test is now considered as the first test that a medical student takes in the medical school. That's their first test in the medical school. So the consequence of that is that the admission test is part of the curriculum. So it should follow the curriculum. And how are curricula built? Our earlier two speakers told about this. So they are all competency based. So the curricula follow competency frameworks. So in that case, the admission test also should follow the same competency framework. But there is a problem. The problem is our competencies in the medical school have these: clinical skills, practical procedures, clinical reasoning, and so on, which are very technical, and an entrant, an applicant will not know this because they have not gone through the medical school. So then to answer that, we have to change the way that we think in assessing an applicant. That is the next concept. Admission test should not assess the achievement of a competency, but it should assess the potential to be trained, or in other words, trainability. So if we test in the admission test the trainability, how trainable is this applicant, probably we can still follow that, not probably, there are examples of people following the same competency framework that the medical school has or that country has to admit students. So then the consequences is admission tests use simulated or past behavior scenarios to test these abilities, not in a clinical sense or a medical sense, but in day-to-day sense. So for example, clinical reasoning is often tested as verbal reasoning. Practical procedures, you can't test lumbar puncture and vena puncture, but certainly you can test how the manual dexterity, how good a person is with their hands. So another common way of testing that is hand-eye coordination, because that is the basis of all manual procedures. So with those three concepts, let me go on and sort of discuss what is already known with regard to admission tests. So we have a gamut of admission tests. We means in the world, we use only a part of it. So literature evidence is there that academic achievement is very much predictive of future performance, but that alone is insufficient. There are various reviews, surveys, needs analysis which talk of humanistic qualities, attitudes, non-academic skills which are equally important, which we heard in the morning as well. Then how about the interview? Interviews are often used to assess these attributes, but do they work? Well, the evidence suggests that the old-fashioned interview does not really predict the future medical school performance. So there are various problems with such interviews. There are various biases. And perhaps also, because of those biases, as well as because only 2 people are involved in that interview, there can be reliability issues as well. So then, what is known about different methods of assessment for admission is we can broadly divide it into 2 parts. That is pre-admission tests and tests at admission. So pre-admission tests are your secondary school performances. So you can have national level exams like for academic achievement, and for personal qualities you get references from your school principal and so on. What do we know about this? I'll come to that a little later. Then what are the tests at admission? Apart from to test academic ability, apart from relying only on national exams or school leaving exams, which are not really focused on medicine, there are other tests that can be applied which are called aptitude tests. Again, they assess the potential to be trained as a doctor, so or as a health professional. So you have various names like MCAT, BMICH, UKCAT, and so on. And that's for the academic part. And for the other softer part, like skills and attitudes, we have there are many tools that can be used, out of which, of course, one is the interview. Interview is not the old-fashioned interview, but multi-station interviews, or multi-station tests which are not only interviews, but which also have other activities. So here you find for school leaving exams, there is predictive validity quite a lot. For this sort of thing, there is no predictive validity because obviously nobody will give a bad reference to an applicant. Aptitude tests do have, and not the old-fashioned interview, but the tools such as multi-stationed OSCE type of tests, those have good evidence for predictive validity. Right, if I then focus only, because I think the pre-admission tests are not in our purview, so what we can change is test at admission. If I look at that, so knowledge, what are to be tested as knowledge? These are some of the things that can be tested as knowledge, which are applicable to the study of medicine or to the study of health profession programs. Then for skills, these are some of the things that can be assessed and that had been assessed. So aptitude test is the tool for this, and the tool for this is multi-station tests such as structured interviews or structured other active stations. This is the old Miller's pyramid where all assessments are divided into 4 strata or 4 tiers. So the if you apply this to assessments that we just now talked of, that is assessments with regard to admission or selection, then school leaving exams and aptitude tests are the tests for this, to assess the cognitive ability. To assess the other abilities, including communication and all that, at a show-sub level, multi-station tests are good, based on, of course, scenarios, simulated scenarios. But for the DES level, actually there is no test, but there is some evidence to say that there is a interview type called past behavior interviews, where the interviewer will ask the applicant to recall one of his own behaviors or experiences and start probing. That sort of a thing is on your own experiences, so that may capture sometimes the DES level to an extent. But the problem, or the perceived problem here, is that these sort of tests will attract a lot of biases. An interviewer can really trip a candidate. So how to avoid that? How to overcome that? One is, of course, examiner training. And the multi-station format itself does not give a lot of power to one interviewer or one examiner. So there are several stations and several examiners' opinion will count. So that will be an intrinsic way, within a built-in way of avoiding this sort of biases. Then the second obvious one is keep humans away from decision making. Let them observe, let them give an opinion, but the decision should be taken by somebody else, and if possible, that decision, if we can have algorithms, that decision can be away from a human. So this is SLMC website, and if you read this, they are already thinking on this. Principles of responsible AI in medical school and residency selection. However, as we know, AI also can make mistakes. So what is the answer to that? Multiple checks at various points. Don't just allow AI to do everything and get into an armchair, but be always observant and see whether there are problems in the system. Second, of course, there should be a robust appeal process where a candidate can always appeal if he or she thinks that there had been some injustice. And the problem here is these multi-station tests are very logistically intensive. There are a lot of resources need to be there to run these. So there is no answer to that, but at least we can reduce that if we have a two-tier process where first you administer a written test to shortlist, and those who only qualify that written test will go through these type of more logistically burdensome tests. Right, so that's the background that I wanted to talk of. Then what do we do, and where can we go? I think that was the question that I have been given. So out of these, we do this. We do this, and we do this quite well, and that has predictive validity. So I think we should continue doing that, but we can make changes, especially if we can also include an aptitude test also, which is focused on health professions. So that's there, but I think the major, and of course we do one more thing, that is the district basis, and the technical term for that is affirmative action. So there is, there are certain preferences given to certain disadvantaged groups. Again, that is also a known principle in admission. Even the United States, they also practice this. But I think the major gap is here. With or without affirmative action, if we are to select students who are really suitable to practice, not only to learn, then we need to also see whether they are capable of being trained in these much needed skills and attitudes. And for that, I have 3 questions. I don't have answers, but I have 3 questions. Shouldn't the potential to achieve all competencies, not only the cognitive ability, necessary for medical graduates be the basis for an admission test, with or without affirmative action? Shouldn't the criteria for affirmative action be revisited? Because it's now more than that the criteria we follow for affirmative action is about more than 50 years. It first started in the 1950s. So society has changed. So therefore, we can revisit that and see how appropriate it is, and then we can make changes if necessary. And the third question is, can AI be used to find a criterion better than district basis? That is also possible, because we know there are certain criticisms for the district basis, but there can be more individualized. We are in the age of precision medicine, so we can have more individualized criteria for different students, not for groups of students, but individual students, based on his or her circumstances. So, should the entry criteria be revisited? Yes, but how? These are the things that I discussed in my short talk. So, adopt a competency-based admission process as the admission test. So, as the first test in the medical school. Test competencies for the potential, not for achievement. Potential to achieve rather than for achievement. Third, use a battery of evidence-based assessment methods, not just only knowledge tests, but a battery of methods which assess all competencies. Evaluate the methods and adopt adopted frequently and make changes where necessary. Then reduce the role of human judgment. Humans are certainly part of assessment. You can't take that out, but the judgment can be viewed as more valid if the human judgment part can be at least partly taken away by things like AI. And finally, to overcome logistics, adopt a 2-tier process where the knowledge part is first assessed and then shortlisted candidates only go through the skills and attitudes. So those are my key points in this short talk. And that concludes my talk, and I'm open for any discussion. Thank you.
Thank you, Professor Vannamperuma. Now we have listened to 3 very interesting speeches. I think we can allow 1 or 2 very short questions from the crowd.
That was a very thought-provoking session. I'm Kaushla, I'm an emergency physician. My question is to the panel itself. The last talk by Professor Vannamperuma sort of implied that AI may be less biased than human. Is there evidence, or is AI equally biased? And if that is so, how do we use AI in assessment?
I hope you can hear me. It's only an experiment, as you could see in that SLMC website. So when we know that humans are biased, in the sense humans can be biased, then we have to find alternatives. That alternative can be worse. Then we have to ditch that. We need not continue with it. And any change will have to be piloted first. But knowing something is not appropriate, or knowing something that we have to change something for the better, and not doing anything about it and just continuing the same way is not a very good way of doing things. We have to We have to experiment, and if we fail, we can go back, or we can find a sort of a hybrid method. So with AI, I don't think there is much evidence for anything at the moment. But certainly there is potential where a particular way of selecting, for example, what is the best way to combine knowledge test, skills test, and attitude test. We humans will have our take on it, but AI can go through several thousands of candidates, model different combinations, and give us a solution for that. So for that, if we don't use AI, I think we are failing. Thank you.
Just a very quick response. In Singapore, we use AI a lot, and my conflict of interest, I'm a fan of AI. So we use AI quite a bit in assessments, as I mentioned, not only in undergraduate, but in specialist training as well. But there are two parts to it. One is the test construction and test design. And the second part is making some value judgments. Now, AI, any technology reflects the society in which that particular technology is being used. Because you know AI, you have to tune it. It's called tuning. So when you tune it, when you program it, and then when you continue to tune it, it actually reflects on the entire society, or the professional values and all that you are using it. Having said that, in test creation, we use that a lot with what we call the procedural safeguards. And that's what I think Professor Ponnampuram mentioned about, testing and then having an oversight, etc. In the final decision making, we use AI to start the conversations, as I mentioned earlier. AI is not the final arbiter, or will make the final decision. AI will tell us, okay, from this candidate, these are, as earlier, as we were also shared, they will share that these areas are good, these areas need improvement. And then we have a conversation. The panel will have a conversation with regard to that specific student or a resident, looking at all the data, and then make a value judgment about that trainee, and that's a human decision. And as I mentioned earlier, this value judgment can be made very much faster if we use AI to collate all that data. It has the power to collate all that data and give us the much necessary data to make that final value judgment about the trainee. Thanks.
I'm Professor Surendra Kumar, the Dean, currently serving as Dean of Faculty of Medicine, University of Vietnam. So thank wonderful, futuristic and visionary talks, and I really enjoyed that. And also, and both of you know this, three of you also presented. So then Madhava mentioned about the successful countries in the list, and Singapore also one of the countries. So Professor Dujiba, you were there and experiencing. So what I'm asking that, what's the way forward and how we can envisage to achieve that, and what sort of structural and things to be considered for this kind of achievement, like Sri Lanka Medical Council and other stakeholders, to how they can work together and to make it.
Thank you, Suren, for the question. I think the way forward is Sri Lanka Medical Council can take the lead in collaborating with all other stakeholders to formulate a vision and a strategic plan for healthcare workforce development in the country based on the needs. I think it can be a consensus approach, but anyway, then everybody shares the same vision and same strategy. Then we know the roles of each agency in contributing to that. The regulatory aspect can be looked after by the SLMC, the ministry can support it, and the UGC, the universities can contribute to the training part of it. So we know what is actually happening. Otherwise, what happens is the UGC and we know what is happening. The faculties, the UGC, the education ministry do some. We all together do something, and then the ministry is not selling it to the ministry is a challenge, and then the SLMC has a different view, or we might have to get entangled in both parties and all that. So it's not like that. So we do something common, we do something collaborative, and then that's a start.
Okay, thank you very much. Due to time constraints, we may have to conclude this session. Thank you very much once again. Thank you.
We now invite the chair of the session to present tokens of appreciation to our esteemed speakers in recognition of their valuable contributions to this important discourse. And it is my privilege to kindly invite the speakers to step forward and accept this gesture of our sincere gratitude. Professor Dujipa D. Samarasekara. Professor Madhava Chandratilaka. And Professor Gominda Ponnamperama. I would like to invite Dr. Sunil Vijay Singha, Council Member of the Sri Lanka Medical Council, to present a memento to the session chair as a heartfelt token of our appreciation for guiding and moderating this session. Thank you to our distinguished dignitaries for your presence and participation. You may now kindly take your seats as we proceed with the next item on the program. So, ladies and gentlemen, we now commence the fourth plenary session titled Integrating Innovative Technologies and Research. And it is my privilege to call upon Dr. Duminda Samrasinghe, Council Member of the Sri Lanka Medical Council, who is the first board-certified pediatric cardiologist in the country, currently serving at the Lady Ridgeway Hospital for Children. He is the president of the Sri Lanka College of Pediatricians and the past president of the Sri Lanka Heart Association and the chairman of the Children's Heart Project of Sri Lanka. A pioneering figure in pediatric cardiology, Dr. Samrasinghe has advanced the field with a long-term vision and has made significant contributions to its development in Sri Lanka. And I take great pleasure in inviting Dr. Duminda Samrasinghe to the stage to assume his role as session chair. Let us welcome him with a warm round of applause.
Thank you very much. I think we have a very interesting session next. It's integrating innovative technologies and research. Everybody is speaking about next 100 years. I think this is applicable to next 6 months because we are going to enact the Personal Data Protection Act within next 6 months. So we should align with the data protection as medical professionals. We all need to align. So without much ado, I'll invite the first speaker, Professor Bandula Siribaddana, Professor of Medical Education at Postgraduate Institute of Medicine, University of Colombo. He has contributed a lot to the field of digital technology and everything related to innovative AI and everything. So over to you, Bandula.
Thank you, Shah, for the introduction, and it's a pleasure to be in this August session. And can I first of all thank the SLMC Centenary Committee for the invitation as well as the opportunity to share some thoughts in relation to technology and its use in medical practice. So I'll start off with a concept that kind of has risen through the ashes and is being debated significantly these days. The concept of technological singularity. What it basically suggests is there is a point in time at which point the machine intelligence will overcome the human intelligence. we might think that it's already here, but we are not. But actually, once it surpasses this point in time, the evolution is exponential to the extent that there may not be much of a control by the humans. And plus, the impact of that exponential evolution of intelligence will impart an irreversible impact on the society that therefore will change the civilization forever. And this is what Stephen Hawking mentioned as the worst event in the history of our civilization. We can be happy that we are not yet there, but it might come. But having said that, this is another concept that has kind of emerged with any technology over the last probably 50, 60 years, which has some intelligence which potentially could replace human intelligence. But it has never really gained momentum until now. So let's move ahead with this thought in our head. But should SLMC think of tech? That is another question that I would like to start off with so that it will kind of remain in our mind. Well, the answer to this lies in the vision and the mission. Vision is for a health system in which the patients are treated and cared for by competent humane, ethical, and safe healthcare professionals. And the mission is to protect, promote, maintain the health and safety of the public by setting, maintaining, and raising standards of education and practice of healthcare across the country. If tech is the one that's going to impact many of these aspects in terms of training, practice, in terms of care, yes, SLMC does have a role. With that, I'll get into my topic. In digital health, telemedicine, and data privacy, transforming patient care in a connected world. It touches upon three key important areas, but not necessarily all, but I will try to link these three concepts in a way that we will understand, okay, what probably is our role as health medical professionals, but at the same time, what's the role of a governing body such as SLMC? First of all, I'll go into some of these concepts one by one. Digital health. You already probably know that it's an umbrella term that refers to many things. You can see this in this illustration. It refers to things like big data, mHealth, health apps, wearables, anything that kind of make use of ICT or information and communication technologies. You don't see AI here. So where's AI? AI is everywhere. All of the components that you see here and which you don't see here can and will be influenced by AI. And therefore, it's already mainstream. It's already there. So as a result, everything technology will be influenced by this emerging trend. Telemedicine is the care of patients or provision of care when there is a separation by distance between the two parties. So the medical professionals using video communication technologies to care for or communicate with patients can be considered telemedicine. And that imparts its own influence in how we deliver care as well as how we regulate. Data privacy, on the other hand, it refers to the control a person will have in terms of his or her personal data. So we all know that unless we give consent, our personal data should remain with us. And we should be able to share it whenever we need to acquire care from a health professional. That should be the norm. But maybe that's not happening as it should. But why should we care? Because this is where we are at. The healthcare is one of the highest in terms of influence by cybersecurity breaches since 2022. It has a rise in 8.2% according to IBM Analytics, with a cost of about 10.11 million overall in the US. So it does highlight an important area which needs to be sensitive to. Now, let's go into examples of each of these elements to understand what its implications in terms of regulation and in terms of what the SLMC might do with it. For example, let's take a diabetic patient who's being cared for. This is how we have, in general, cared for a diabetic patient in the past, right? Patients come for a monthly clinic, blood sugar levels may be manually recorded and entered into the book. And then doctors may not be able to see what they are doing, how they are maintaining, or how they are managing themselves, except for that visit that they do monthly. So mostly our care is reactive rather than being proactive. But now we have the technologies to monitor the blood glucose levels continuously, evolving technologies. Data can be shared in real time, so whenever there is information related to the patient's conditions, it may be communicated to a practitioner. AI may be used in terms of assessing the risk and then making predictions, and then therefore alerting the healthcare professional as well as the patients. And then it may also suggest certain practices or advice for that particular patient. These technologies are already there, so it's not necessarily the future. And the implications in terms of bodies such as SLMC might be very vast. It may be about standardizing the monitoring tools, digital literacy, ensuring how AI tools are used safely, and how effectively care providers can provide care using data-driven models. All these require meticulous attention because it has the potential to deviate from the norm. Let's take an example of telemedicine. The past practice, a snake bite. You need antivenom, but there may not be much expertise in terms of giving it. There may not be toxinology experts. Delays may occur and life may be lost. But now you have the ability of consulting a practitioner who's far away, who will be able to give you that advice and guide the doctors in providing the care in a timely manner. Therefore, we can actually manage the patients in their own setting, saving much needed time. But then the implications of that is the platform separates the carer as well as the patient, which essentially means that we need to now ensure whether that particular provider has the necessary capacity or the skills to deliver care over such a platform, and how to ensure that the data that is being transferred is secure and that nobody else will get hand of that. And also whether these monitoring platforms are also accountable in terms of the care that is being provided. Then when it comes to data privacy, it may be something like patient data being stored in a paper file, which probably accessed by only one person in a hospital setting. Given the physical nature of its storage, it's very difficult to breach that data unless you can find the file for yourself hanging there for about an hour and entire day maybe. But the current practice allows the data to be efficiently stored, accessed, used for the care, but at the same time for data breaches. Data may be lost in millions, and it might cost millions. So which again then provides avenues for the SLMC or any governing body to look at standards of such access. How do you store such data? What's the governance modules in terms of getting consent and sharing of data? And how do you collaborate with ICT regulators? All these kind of emerge with such technologies. Let's jump into a different dynamic that is emerging. These are some of the pharma companies that you know of. In recent times, these pharma companies have gained into collaborations with AI companies, which essentially means that they are looking at technology as another category, not necessarily as a tool. And which again essentially means that huge investments are made. This is what you see in PubMed when you search for AI-related research, or not necessarily technology, but AI-specific research, an exponential increase in research in recent times, going into thousands. And these are not clinical trials, mind you, but if you look at the clinical trials, similar trends. If you look at the FDA approvals in terms of AI and ML devices, this is what you see, an exponential rise again in terms of devices. This indicates the investments going into it, not necessarily researchers being interested, but investments going into it. And as a result, now you see there are technologies emerging in different health segments, which essentially captures intelligence, largely in radiology-related areas. Those radiologists who are in the audience need not to worry, though, yet. Cardiovascular, neurology, and all sorts of areas are in the list. And I was wondering, being a medical education, why medical education is not there. Dr. Dujip and all might also be there. There are two reasons for that. Either nobody's interested or we are already obsolete. So this is how things are changing. This is how technology is being introduced. And then we ask the question, can AI be inaccurate? Yes, it can, because the ability of an AI to be accurate or be effective will depend on how it was trained. And if it is not trained in a proper manner, there are so many ways in which that the model might work inaccurately. And that can happen. For example, an AI model that is trained to detect skin conditions in a Western country where on white-skinned people might then work differently when it is used in a country such as ours. So it requires our researchers, our technologists, our regulators to move in. Otherwise, the technologies we use must not really match our context, nor our patients. Then what is the world thinking in terms of technology? There is multiple attempts at regulating. This is important for us to know. There is an effort which I'm happy to say that a lot of inputs coming from Sri Lanka for a global reference framework on health data governance. A draft has already been done, which is being shared, and we are going for global consultative process in the coming months. And this will basically allow countries to adopt high-level principles in their own context. Then the WHO framework of principles in ethical application of AI, these are things that we can adopt. We can actually use in regulating our own selves. What is there in Sri Lanka? Well, we have the National E-Health Policy. We have a Data Governance and Protection, Data Protection Act. We have standards and interoperability introduced by the Ministry of Health. And we have also cross-sector standards and oversight, such as the Online Safety Act and so on. But at the same time, we also have a cohort of experts in the form of health informaticians in the Ministry of Health itself. Probably nowhere in the world we have such a cohort existing in a single institute in a country. Basically, that essentially means that we can actually take proactive steps rather than being reactive. Now, what does it mean in terms of SLMC? Well, there are several things out of which I have just listed a few here. Not to say that the SLMC has not taken steps towards this. Already there are steps taken, but some things that need that to be for us to consider collectively. Integration and investments. Initiatives to upskill medical professionals is a must, because if you are using a telemedicine platform, it's important for the professionals to know how to provide care using such a platform, because it's different to interacting with a patient just next to you. So that skill needs to be imparted. At the same time, how you handle consent, how you handle data, how you secure data, everything needs to be known by a medical professional. Then equity and governance. The SLMC and the governing bodies should advocate for data privacy, because technology evolves rapidly, and if you stay back and look at it, until it evolves, things may have moved beyond you. So it requires a patient-centered digital health that will help everyone to benefit from it, rather than only one segment. Then the vision for the next 100 years or so should also be driven by what we see as a rapid evolution in technology. It's innovation, equity, and data-driven, and that's something that needs to be part of how we consider governance. Well, I asked the ChatGPT to show me how we care for a patient at present moment. Well, it's close enough. Then I asked to show, okay, what can happen in 10 years' time? This was what it showed me. Use of maybe telemedicine platforms and so on. Then I asked, okay, what can happen if it is what, as Prof. Hawkins mentioned, what can happen? This is what will happen in SLMC bicentennial celebrations. The interesting thing is the guy who got replaced. In a way, in a cynical way, it also kind of telling that the people who are in rural areas will remain the same. Whatever happens after a century of care. But then this basically kind of highlights what can happen in a way for us to think. The ball is now in our court, so it's time for us to make the next move, and this probably is the right step towards that. Thank you very much.
Thank you, Professor Bandula, for that very informative lecture. We have the next speaker is Professor Anuji Upekshika Gamage. She is the chairman of National Research Council. She's going to speak to us on translational research and innovations from bench to bedside in Sri Lanka medicine. Thank you.
Good afternoon, dear sir, madams, colleagues, ladies and gentlemen. Somewhere, something incredible is waiting to be known. I'm truly honored and excited to be invited to speak under the theme, Integrating Innovation, Technologies and Research at this momentum occasion. And also a bit terrified because all my teachers are also in the audience. Looking back over the past 100 years, it is fascinating to see how health in Sri Lanka has evolved. We have marked with significant progress as well as faced persistent challenges. Considering research and innovation, while there have been many positive changes, there are also aspects that we have not even looked at. Keeping in mind that, first of all, we should do no harm. So at the background, there is a picture of ancient Puskolaputta, used to keep account of traditional medicine. So this is not new to us. These historical origins of Sinhala medicine can be tracked back to ancient civilizations, back to King Pandukave, with the practice of receiving substantial support from Sri Lankan monarchs who possessed extensive knowledge in the realm of medicine themselves. So talking from bench to bedside to patient care, I would like to talk to you on translation, innovation, and even implementation. So what is translation? So bench to bedside occurs through translation. Bench to bedside is a process of translating science, research conducted in laboratory, which is the bench, into clinical applications and patient care, which is the bedside. So it is basic sciences, translation to humans, translation to patients, and to translation to practice, and finally to communities. And now note, less than 25% of promising biomedical discoveries progress into clinical trials. And of that too, less than 10%, a small fraction, makes it to clinical practice within 20 years. Well, that's the norm. Sir Alexander Fleming discovered penicillin in 1928, but when it was marketed, it was 1940, which is not a problem. Well, when we consider research, translation of research is a continuum. From basic biomedical research, discovery, design, validation, pre-clinical trials, clinical trials, late clinical trials, health technology assessment, healthcare research, and finally delivery. So we see two translational gaps here. The first translational gap and the second translational gap. However, the problem is now we focus too much on the first translational gap and we forget to think about our second translational gap. So due to these processes, due to these lack of interest, we lost research in this process. 85% of research is lost in this translation according to Chalmers 2009. So why does it happen? Study designs and methodology, methodological flaws, research prioritization and funding. And even if we do get funding, M&E during funding. So we lack monitoring and evaluation of projects which got funded. Regulatory and ethical bottlenecks, publication and reporting bias, which is also referred to as winner's curse, an economical term. Knowledge dissemination and uptake. We researchers, we scientists, we cannot market our own research. For therefore, we fail to sort of get these into policy decisions. Right. Talking about methodologies. What would you say if a clinician, if a doctor prescribes wrong drugs to a patient? Okay, or the right drug, but in wrong, inaccurate doses. Scandalous, right? Unacceptable. Right? So this is what Altman 1994 highlights. Unacceptable, unprofessional, scandalous. But what happens? Let me draw a quote from this very same paper. What should we think about a doctor who uses the wrong technique to do research? What would we think about such a doctor? The temptation to behave dishonestly is surely far greater now, when all too often main reason for piece of research seem to be to lengthen a researcher's CV. There may be greater danger to the public welfare from statistical dishonesty, from almost any form of dishonesty. Why should we think it acceptable for researchers to ask the wrong question, use the wrong techniques, and even wrongly misinterpret? The danger to welfare loss due to statistical dishonesty is far too great. Something that SLMC should pay attention to. Okay, let's go to the current landscape of research funding in Sri Lanka. We have limited government allocations for research and development, less than 1% GDP. And then we also have university-based research grants, largely self-funded or dependent on large or small case competitive grants, local or foreign, donor-funded projects, research often embedded with external funded help programs, private sector philanthropy, minimal engagement in research funding. For instance, Wellcome Trust, a global charitable foundation established in 1936. Do we have such institutions or contributions to research? So, what are the health research funding agencies we have in Sri Lanka? National Research Council, National Science Foundation, Ministry of Health, Ministry of Education, SLMA, and other professional bodies. Now, this slide is really interesting. Once I joined NRC only, I got to know there are so many institutions, a lot of scientists working together to improve science and even research. Arthur C. Clarke, NRC, NSF, Sri Lanka Inventors Commission, National Innovative Agency, Sri Lanka Institute of Nanotechnology, SLINTech as we call it, Sri Lanka Institute of Biotechnology, SLIBTech, Industrial Technology Institute, ITI, National Science and Technology Commission, NASTEC, Sri Lanka's Standards Institution, National Engineering Research and Development Center, National Institute of Fundamental Studies. Now, all these institutions, from inception, innovation, commercialization, and even scaling up of research, do we know about these institutions? This is high time we do so. Okay, loss in translation. A second reason is we do not know our priorities. So if we do research for the wrong purpose, nobody's going to use it. Okay, so a few weeks back, Ministry of Health launched these health research priority areas for 2025 for the next 3 years or so. Now, these comes under allopathic health research, Ayurveda health research, and under various topics and subtopics. Okay, so let's move on to innovation. Dr. Sanjeeva Veeravanna, in one of his TED Talks, talks about two types of people. People who look at a problem and complain, and another set of people who look at a problem and wonder, how can we overcome this? So, there is a dearth of innovations in Sri Lanka. We have to accept this. Innovations need time, passion, dedication, thinking, support, and also resources. Plus, innovations need systematic and multidisciplinary efforts of all who contributes. And there are 6 forces definitely to be considered under innovations. Industry players, public policy, technology, we have talked so much about technology today, funding, accountability, and finally, the patients. Unless these 6 forces are acknowledged and managed intelligently, any of them can create obstacles for innovation. So we were talking so much about health technology in the morning. What is health technology? When we talk about technology, what comes into our heads would be MRIs, scanners, all these equipment, computers. But health technology is something that we use to promote health in a person. It could be a drug, investigation, building, screening, and even maybe policies. So what is HTA? HTA takes us through reasoning. Would this technology be suitable in my country? Can it work in my country? Quality and safety of the technology for my people and the need in the community. And it also looks at safety, efficacy, effectiveness, appropriateness, and implementation. Sadly, we do not have health technology in Sri Lanka. HTA considers the broad implications of a technology, including its impact on society, ethics, and how it integrates. So it can be, we looked at the translational process. If we divide that into upstream, midstream, and downstream, HTA can be applied to all these places, including identifying a promising area for tech development, evaluate feasibility, effectiveness, and context fix, guide adoption, decision, and monitor impact. Technology assessment should be embedded, iterative process in the research ecosystem, starting early, continuing through development, and informing policy and practice. Into the last slide, implementation from bench to bedside to patients. Now, in low resource setting like ours, implementation research is very scarce. Why? And then this leads to, we fail to identify whether these technologies or drugs that we talk about, whether this would be acceptable in the community, whether these will be adopted by people or patients, appropriateness, feasibility, cost, and penetration, and of course, sustainability. So bench to implementation, why does it matter, our implementation research? Do we even think about it? It improves population health outcomes, enhances return on investments in research, informs policy, planning, and programs. But consequences of poor implementation research, what would it lead to? We waste a lot of resources. Persisting health inequities, delayed or missed innovation. So all these reasons lead to research waste. The scandal of poor medical research. Too much medical research is conducted but never published, never repeated, and probably not even used. Consequences, we waste a lot of resources. Plus, we lose public trust. Now, some statistics from the Ministry of Health, which I took from Professor Rohini Senviratna, my teacher, my supervisor. Now, of the total abstracts received, 504, 42% have been rejected. Why? Because due to poor quality. And for 3 years, 2011 to 2014, number of the research that have been conducted, 159, and only 159 was published, if at all. Presented mostly at annual scientific sessions. 86% was presented at various scientific sessions. So how can we prevent this? Again, better study design. The biggest problem is flaws in methodology. And also study registration, pre-registration of protocols, promote transparent and open access of research, encourage collaboration and data sharing, focus on addressing actual evidence gaps, focus on implantation and the real-world integration. And now, support with economic impact of research. Impact, it's the good the researcher can do to the world. Impact could be on people, places, or even processes. The economic and societal impact is the effect of change or benefit to the society, economy, public policy, and service. Types of economic impacts that we can do, assessments we can do, cost saving, budget impact, return of investment, cost effectiveness, cost minimization, cost benefit analysis, etc., etc. Now, this is high time we incorporate this evaluation into our research. This plus risk assessment. So at onset, we know, okay, this is what we are going to deliver to the country. This is the return on investment. And later on, when you start with knowing your risks, it's really beneficial. You face it, you anticipate it. So from next year onwards, NRC, the evaluation criteria plus our applications will incorporate these facts. So why economic evaluation matters? We prioritize cost-effective interventions, avoid investments in ineffective or high-cost, low-impact interventions, ensures optimal use of public health budgets and donor funds. If we don't do so, unused local innovations due to lack of demonstration value, public and policy resistance due to unclear return of investment can happen, delayed adoption of interventions with proven efficacy but unknown affordability. Last slide. Bench to bedside. There are gaps we need to fill. Translational research to innovations to thinking of how to deliver this to the community more effectively and efficiently. Therefore, we need less research, better research, and research done for the right reason. Quality over quantity. To support my statement, I end with a quote. I would propose that the delay is mainly due to our inability to understand and to integrate. Keeping in mind, first do no harm. These are a few references that I used. I thank you.
Thank you very much, Anuji. Thank you. Please join. I think, do we have time for questions? No, okay. We have to end this session. Thank you very much to both speakers. Thank you.
And we now invite the chair of this session to kindly present tokens of appreciation to our distinguished speakers in recognition of their insightful contributions to today's important discussions. I invite our speakers to please step forward. Professor Pandula Siribaddana. and Professor Anuji Upekshika Gamage. May I invite Dr. Janaka Pushpakumara, Dean, Faculty of Medicine and Allied Sciences of Rajarata University, Council Member of SLMC, to kindly come on stage to present a memento to our session chair as a heartfelt token of appreciation for his guidance and moderation of this session. We sincerely thank all our distinguished speakers, and I kindly invite you to take your seats. As we proceed on to the next item, ladies and gentlemen, we now come to a distinguished highlight of our program, the keynote lecture titled The Vision and Future Direction of the SLMC, a New Medical Act for Sri Lanka. And to introduce our esteemed keynote speaker, I'm honored to invite Dr. Sunil Vijay-Singha, who is the Senior Consultant Orthopedic Surgeon at the Lady Ridgeway Hospital for Children in Sri Lanka. Dr. Vijay-Singha has completed multiple international fellowships, contributed extensively to peer-reviewed journals, and delivered numerous lectures on pediatric orthopedics at both national and international forums. He is currently a council member of the Sri Lanka Orthopedic Association and a council member of the Sri Lanka Medical Council. May I now respectfully invite Dr. Sunil Vijay-Singha to the stage to introduce our distinguished keynote speaker.
Thank you. As you mentioned, I think we have come to the highlight of the day. And to talk to us on the vision and future direction of the SLMC, a new medical act for Sri Lanka. It is my pleasure and privilege to invite Professor Janaka De Silva to the podium. And he is not a stranger to this audience. He is a very active consultant physician and a council member of Sri Lanka Medical Council. And he is Professor Emeritus of Medicine at University of Kelaniya and a council member of the Sri Lanka Medical Council. Over to Professor Janaka De Silva.
Thank you, Sunil. Distinguished guests, ladies and gentlemen, being 100 years old is a proud achievement for any institution. Nevertheless, to remain relevant in the eyes of the public and the profession, we must move and evolve with time, because the number of medical schools, medical education, and medical practice keep changing over time in their nature, scope, specialization, and geographic distribution. And I want to say that here, when I say medical, I actually imply both medical and dental. In addition to this, the expectations and needs of individuals and society have also changed and become more demanding. Regulators such as the Medical Council have to adapt to the current global trends in medical education and practice, as was espoused the whole of this morning, and be more accommodative of modern societal needs. In a manner to achieve these objectives, and I think my fellow council members will agree with me, we are constrained by a 100-year-old medical ordinance, even with its 32 amendments. Because of this, the Council decided on drafting a new medical act rather than enacting even more amendments. And this draft medical act has attempted to rectify the limitations in our old ordinance in keeping with current aims and the objectives of the Council. In doing so, we did not try to reinvent the wheel. Lessons learned from regulators in other countries, as well as our own past experiences, were given due consideration when we drafted this act. Now, the primary objective of the Sri Lanka Medical Council is to ensure public safety in healthcare in our country. It does so by guaranteeing that registered medical practitioners have the necessary skills and experience to practice medicine, and regulate this in a manner that minimizes the impressions of being unduly punitive, but at the same time improves the trust among the public, practitioners, and academic institutions. And I think Justice Kodagoda said a similar thing when he talked this morning. So the new draft Medical Act retains many valid sections of the current ordinance. Amendments have been made to strengthen several other sections, but new sections were included, especially in important areas that were only indirectly addressed in the current ordinance, like accreditation of medical schools, professional ethics and fitness to practice, patients' rights, regulation of advertising, interim prohibition orders to deal with quacks, finance and audit, and so on. So in the next few minutes, I would like to highlight briefly to this audience some selected amendments incorporated into the draft act. And I think it will be of particular interest to our local delegates because it is an act for Sri Lanka. Now, the importance of a regulator being held accountable, the SLMC being held accountable, cannot be overemphasized. If not, corruption and mismanagement will surely result. The lessons learned from the dissolution of the Indian Medical Council in 2018 due to allegations of corruption, which were principally in relation to medical education and failure to regulate the medical profession, is a case in point. The draft act that we have written attempts to further strengthen the governance of the Medical Council. The Medical Council is now unequivocally, legally recognized as a state-owned enterprise. And you'll be surprised that this recognition came very recently, not even a couple of years ago, if I'm right, Vajra. However, with financial and administrative independence. What this means is that we are ultimately accountable to the government. And we must adhere to administrative and financial regulations. For legal matters, liaise primarily with the state regulator, and that our finances and assets undergo external audit by the government auditor. The new draft act emphasizes these points. When drafting a new act, the composition of the council was discussed at length by the drafting committee. because the number, composition, and the method of appointment to medical councils vary widely worldwide. We felt that the numbers should be manageable. It shouldn't be absurdly low, like 4 or 5. And some countries in the past have had a membership of over 100. So it has to be manageable. The composition of the council, we felt, should have both medical members for their knowledge of the standard of care and the work environment that our doctors work in, as well as lay members who will promote the public viewpoint, and having them will definitely increase the public's trust. The appointment, how they are appointed, whether it is by election or appointment or ex officio, there are pros and cons. And if I talk about the cons, members elected by the profession may be influenced by the electorate. And members who are appointed, if they are appointed by politicians, may be influenced by the politicians. Unless, of course, the appointing authority is an independent, respected body like the Privy Council in the UK. If you look at a cross-section of medical councils, and this may interest the audience, the numbers vary from about 10 to 15 to usually about 25 to 35 members. So the GMC in the UK and the New Zealand Medical Council have 12, the Irish Medical Council has 23, the Singapore Medical Council 27, the Australian Medical Council 30, the Malaysian and the Indian councils have 33. So roughly about 25 to 30. Most, but not all, include medical and lay persons in various proportions. I could find only the Irish Medical Council that had more lay persons than doctors. The GMC has equal numbers, and most of the councils there are more medical people than lay people. Singapore is an outlier. It has no lay people in the medical council, and they co-opt a lay person only for their disciplinary committee. So that's an outlier. Appointed and ex officio versus elected by the profession, the GMC is appointed, all of them. The National Medical Commission of India is either appointed or ex officio. And then the others have a mixture of both appointed and elected. And again, a slight outlier is the Malaysian Medical Council that has more elected members than appointed members. So it varies widely. And I think this reflects the many different functions that are expected from the councils, the expertise they require, the attempt to maintain public trust, accountability, and governance, and also local sensitivities. So the draft Medical Act for the Medical Council here, Sri Lanka Medical Council, ended up with 32 council members, 14 elected by the profession, 11 ex officio, mainly deans of faculties and so on, 7 appointed, of whom 6 are lay persons. So that's a new thing for our medical council, the inclusion of lay persons into the Sri Lanka Medical Council. Accreditation is a very important function of a medical council. And as we heard this morning, the WHO recommends accreditation of medical schools by an independent agency to ensure the quality of medical education. The council performed this function all this time. However, the word accreditation is not even mentioned once in the old ordinance. So this was a thing we had to change. So an accreditation unit has been established by the council. The draft act has strengthened its position as an independent decision-making body. All matters concerning accreditation have been delegated to the accreditation unit. Be that as it may, the decision on accreditation has to be ratified by the council, because it is not the accreditation unit that recognizes a medical school, it is the Sri Lanka Medical Council that recognizes a medical school. Now, two areas that have not been given enough prominence in the old ordinance and which have now been included in the draft act as separate sections are professional ethics and fitness to practice and patients' rights. They should have been highlighted in the old ordinance. It was not the case. The Medical Council must ensure that practitioners are fit to practice, as determined not only by their professional conduct and competence, but also by their physical and mental health. You don't want a psychiatrically ill doctor treating you. That's the crudest example I can give. And the council does so, or should do so, by formulating guidelines on the expected standards and procedures to follow if concerns are raised regarding violations of these standards. Equally important. And the new act, among other things, requires practitioners to develop and maintain professional performance, contribute and comply with systems to promote patient safety, communicate effectively with patients and work collaboratively with colleagues, and maintain public confidence and trust, and more easily said than done, have empathy and respect for patients. So at least these are included now, and violations of these can be investigated. The other was patients' rights. So the council must and should ensure the rights of patients. And this, the act says, should be by formulating and making public guidelines on patients' rights, so that the patients know their rights. And also what recourse the patients will have when these rights are violated by practitioners. So both of these are important. And these include the right to informed consent. And I put this in because of the commercialization that is taking place in our private healthcare, that informed consent should include the names and qualifications of the healthcare providers, and importantly, the estimated costs of the investigations and treatments that these patients may receive. The others are the right to refuse consent to treatment, confidentiality, information regarding the illness, and adequate medical leave, which we all know. The draft act, I'm happy to say, carries a section on advertising and telemedicine. It was just talked about a bit earlier. And it stipulates that a practitioner can advertise as being entitled and qualified to practice only in accordance with regulations under the Act. So I cannot go on the newspaper and say, here is Janaka de Silva, I can cure cirrhosis. So it's now governed by the Act, what I can advertise myself about. And mention has been made regarding telemedicine, which is the remote provision of clinical care by using telecommunications and digital technologies, especially about cross-border telemedicine, where the Act now stipulates that people should comply with medical licensing and regulations of both the providers and the patient's countries. I don't think it happens these days. There are so many foreign doctors from the region who our patients consult in cross-border telemedicine, which is simply wrong. They shouldn't be allowed to do that unless they are registered here. And the Act stipulates that they must adhere to international data protection laws that Pandula was talking about and patient confidentiality protocols of both countries. So when you are doing cross-border telemedicine, your own country and in the country that the patient lives, regulations of both countries should matter. Now to complaints. This is an important area, and I was completely dazzled by Mr. Kodaguda's talk this morning. Now, dealing with complaints is an important function of a regulator, but I think it requires a fine balance. It should minimize the impression of being unduly punitive. And on the other hand, as he says, the flip side should improve trust among the public, the practitioners and the academic institutions that justice is being done. Currently, it is a two-stage process by committees consisting of members of the council, all of whom are medical. The preliminary proceedings committee of 5 people, and the recommendations are then submitted to a 10-member professional conduct committee for formal investigation and order, all of whom are medical. Now, the complaints must be in the form of a sworn affidavit, and I must say this would discourage many people from complaining. And all complaints, however trivial, and I'm sorry to use the word trivial, I have no right to use the word trivial because when a person complains, it's a complaint. But if we can consider some of them trivial, all of the complaints, the serious ones and the trivial ones, have to be dealt with similarly. So the amendment included in the draft act includes a complaint panel which will hold an initial inquiry into complaints which can be made only with proof of identity. We still don't like anonymous complaints. And that complaint panel may mediate and settle the matter and give order. Or, in the case of more serious complaints, may direct the complainant to submit the complaint to the preliminary proceedings committee with an affidavit. All these committees dealing with complaints will include medical and non-medical members in a step to improve public trust. And there is also an appeals process against decisions or orders made by the Medical Council, which has been written into the new act. These amendments, we feel, may reduce the reluctance of people to complain as well as reduce the burden on the more challenging quasi-legal processes. So, it will weed out the more trivial things so that we have enough time to deal with the more serious complaints with the current system. The amendments also include whistleblower protection, the protection of an employee from the employer for providing information to the council concerning violations of the provisions of this act. It's an important concept. And also, in the case that a complaint is found to be false and malicious, and of which there are a few, now it is stipulated that the complainant may be liable for prosecution. So that should deter malicious and frivolous complaints to a degree. This should interest the local audience dealing with quacks. So unregistered individuals practicing medicine, or quacks, is a lingering national problem. Not only here, the worldwide, but we hear of this in this country quite a lot, especially in our rural areas. And there is public criticism of the regulator for being unable to deal with the problem, and we cannot deal with this problem under the current provisions of the ordinance. So, the draft act proposes interim prohibition orders prohibiting unregistered individuals from providing health services or using a specified title protected under the act, and the complaint can be made either by a member of the public or initiated by the council. And it is initially evaluated by the complaint panel, so you don't have to have an affidavit to complain, and who will then report it to the council for decision and order following due process, giving them the right to explain themselves, and then, of course, importantly, prosecution for non-compliance with the order of the council. So that's a sort of a bird's eye view of the new act for the audience. So, ladies and gentlemen, in conclusion, our vision for the future is a regulator that is independent, although accountable to government. A regulator that ensures public safety in healthcare, and a regulator that regulates in a manner that is not unduly punitive, but also improves trust among the public, practitioners, and academic institutions. And we hope to achieve these goals through the Draft Act, because this Draft Act has attempted to incorporate these ideas. And I'm happy to say it was unanimously approved by the Council, not once but twice, and it has been submitted for necessary approvals before being enacted, an event we eagerly await. An event we very eagerly await at a time, especially at a time, when several unfortunate incidents have taken place and has shaken the trust in our profession. And I think it is timely that we get this act enacted, because it has a lot of things that were not in the old ordinance where we can deal with the problems that we have. Ladies and gentlemen, this is not the first time an attempt has been made to draft a new medical act for Sri Lanka. Those attempts were unsuccessful for reasons I will not elaborate here. But I'm happy to inform you that this time the present Minister and Deputy Minister of Health have both expressed their fullest support to enact this new act. And I wish to end my talk by warmly thanking members of the drafting committee, the legal unit of the SLMC, and members of the council for taking this act to the level it is thus far. Thank you.
Come and sit here. Thank you, Professor Janaka De Silva, for giving a bird's eye view on the new Medical Act of Sri Lanka. That is a vision and the future direction of the SLMC. Thank you very much.
It's now my honor to invite Dr. Sunil Vijay to present a token of appreciation to our respected keynote speaker, Professor Janaka De Silva. Thank you very much, sir, for your profound insights and inspiration shared with us. Ladies and gentlemen, before we proceed to the next segment, please be informed that refreshments will be available from 3 to 4 p.m. at the Lavender Hall, and you're warmly invited to partake at your convenience. However, kindly note that the program will continue without interruption, so we respectfully request that you re-enter the hall quietly should you step out during this time. We now proceed to the next segment, a chair-led and moderated audience discussion on SLMC's future. It is my pleasure to invite Dr. Sunil Vijayasinghe, Council Member of the Sri Lanka Medical Council, to guide and moderate this insightful and future-oriented discussion.
Yeah, thank you. I mean, a bit behind time, but we will try to ask few key questions about the future of the Sri Lanka Medical Council, a new medical act for Sri Lanka, because it is very important part of this centenary celebration. And after Professor Janaka De Silva's thought-provoking note, the keynote address, I think we have the opportunity to reflect, engage, and look forward. So our aim is to have a very candid, constructive dialogue about the direction of the Sri Lanka Medical Council to take over the next century, particularly in the light of proposed new medical act. I will begin by posing a few questions to our distinguished guests and then open the floor for comments or questions from the audience. So my first question is Professor Janaka De Silva. Hope he's here. Oh, sorry. Give him a mic. So my question to you, sir, how do you envision Sri Lanka Medical Council's role in balancing a future where there is increasing commercialization of medical care that you mentioned in your talk as well?
This is the first time you call me sir.
So that is in the official way.
So it's a difficult question, but I think the answer is probably three-pronged. One is that the regulator...
Can you take the mic? Yeah.
One is that the regulator should be fair but firm in his decisions on any wrongdoing by the medical practitioners. The second is by educating our practitioners regarding what is expected when we say professional ethics and fitness to practice and so on, so they know when they're doing something wrong or something irregular. And most important, educating the patients, the public, about their rights and what recourse they have if their rights are violated. And one of the things about what Professor Vajira Disanayak was saying is there's no point in having patients' rights for the public unless the public knows what they are. So the publicity about these rights is also important. So give the public knowledge of their rights and what recourse they have if they are violated. Educate or inform and emphasize to the profession, the practitioners, about their professional ethics, fitness to practice, and their responsibilities. And then when these are violated, then the regulator must act fearlessly and firmly when these things are violated. And that's the only way we can control this kind of malpractice that happens in commercialization of medicine. I hope that was not a crooked answer.
Anyway, the audience can, come out with your questions. So my second direct question is to the president of the SLMC. Of course, based on the draft new medical act that Professor Janaka De Silva has outlined, of course, everyone agrees that the whole council agrees. I think now after this centenary celebration and the publicity we have given to the Sri Lanka Medical Council, the rest of the country and the administrators and the politicians also will agree with us that it is a necessary requirement for the country in terms of patient safety mainly, and for the medical council to have a better legal framework to do its function. And based on that, Professor Vajira Disanayak, what challenges do you anticipate in implementing reforms, and how do you plan to overcome them?
Thank you very much. The process is going to be a bit of a long one, and we are very fortunate that the Minister and the Deputy Minister is with us on the need for reform and to bringing in a new act. So currently, I think the question that Professor Radhavarna Surya, who was seated next to me, asked was, when is it going to be, presented to the wider community? So currently the act is with the Ministry of Health, and the Ministry, for its internal evaluation, has appointed a committee, and that committee will go through that and has not been convened as far as I know. So in fact, this morning, seated next to the Secretary of Health, that is what I made, I emphasized on to him. He appointed the committee. He must get the committee to meet and deliberate and get it to the next level. From there, it will go to the legal draftsman. And the legal draftsman would look at the act. And I think we are very fortunate with Mr. Nanakara, our head of legal. We have a strong in-house legal team. They have put the legal, they have put the legal wording into it. So hopefully there'll be very little refinement that it needs. However, it will undergo the proper legal draftsman evaluation process, and that will take a little bit of time, and then go to the Attorney General for approval. So what the Attorney General does at that point, if I understand that process right, it will look at other aspects. Does it infringe on other laws? How does it place with other laws, and so on? And once his clearance is given, it will be ready to come back to the ministry, and of course go to the cabinet, get the cabinet approval, come back from there with the order to gazette. So once it is gazetted, then of course it will get placed before Parliament. Of course, before placing before Parliament, it can be challenged in courts. So there is, I think, a 2-month period where people can challenge in court. But after the Ministry of Health team, I think, clears it, this will be opened up for public consultation in some form or another. And at that point, members of the profession, the public and others, profession meaning all healthcare professionals, public and others will have the opportunity to comment. So the time, actually, if you put a time frame on it, it is that process that would take the time. It can be as little as 6 months, or as long as many years. And we've all been a part of legislation making, Prof. Janaka. We know laws like the Clinical Trials Act, which started 15, 20 years ago and has now, not even there. And there are similar situations. But we are all committed, the minister and the deputy minister and the health officials are also committed to ensure everybody realizes that we need this, and therefore I don't think this is going to go away. So it's incumbent on all of us to work and get it done. So that is the first challenge. Once that is done, I think we have brought in the institutional changes that are necessary within the SLMC to implement it. We already have the structures there. So I think the implementation would be the least of our problems. Because in the past few years, we brought about all the changes required. We established a strong legal team. We established a strong accreditation unit. We strengthened other aspects, including foreign degree evaluation and so on. So we are ready, I think, as an institution to implement it. And looking at it, I even feel that certain aspects of the new act we are already implementing. So therefore, implementation would be the least of our problem, but let's all work together on getting the act through Parliament, through these processes, and enacted. Thank you.
Okay, thank you. So due to time constraints, of course, I will stop asking some direct questions now. So basically, now it is it's open to the floor. to ask if you have any questions about the future direction of the Sri Lanka Medical Council. Yes, Vinya.
Thank you. I'm Vinya Ariratna, community physician, past president of SLMA. I would like to thank SLMC for actually taking this very important step of introducing the Medical Act. I have a comment and a question. One is that it's very, very encouraging to note that you are proposing patients' rights as part of the Act. We worked together also with SLMC to come up with a charter of patients' rights, which was actually approved by the Sectoral Oversight Committee of the Parliament, last Parliament. And I think a lot of things that need to be probably not included as detail in the Act can be connected to the charter. So that's a comment. Then also, as Professor Janaka De Silva mentioned, I think the SLMC should deal with major complaints and not trivial complaints. Now, how can you ensure that other small complaints are dealt at a lower level? We already have a grievance mechanism. It has been introduced by the Health Ministry at different levels. So I think that also needs to be taken into consideration. My question to Professor Janaka De Silva is, I think Justice Kodagoda made a very important point. That's about kind of a prosecutionary, you call it prosecution role for SLMC, beyond some action that it takes on its own, and establishing complete independence to that particular committee which is going to investigate. Do you endorse that, or do you, I mean, I don't think you have gone into that detail, but is it something that you are considering recommending in the Act?
So the short answer is no, we haven't considered that. And look, I chaired this drafting committee as approved by the council, and everything in that draft act is what the council has approved. So I can't make any personal comments on things like that without the backing and the support of the council. So I think at the moment we haven't thought of things like that, maybe in the future. Vinya.
Yeah. But due to time constraints, I think we'll have... Sorry, Vajay.
Just to add to that, I think Justice Kodagoda's presentation this morning was very thought-provoking. And we must appreciate the fact that that is coming. I mean, to me, when I was listening to him, I thought that it was just not only his opinion, it could be the opinion of the, entire Supreme Court bench. So we really need to take note of that. And so let's see how we, because as I said, this is going to go, this is not going to be enacted the way it is. It will undergo reform. A lot of people will give inputs, and it is incumbent on the council to take note of what Justice Kodagoda mentioned this morning, and I think he would have given a lot of thought before he presented that. It was almost delivered in the form of a judicial kind of, statement. So we will take note of that very seriously, and if need be, present that to the Ministry of Health, because now it has gone from us to the Ministry of Health and it will have to be taken up at that level. So we will definitely consider that.
Yeah, we will. One last question.
I must say, as a former council member, I'm very curious why we are so obsessed about saying not being excessively punitive. I think we have existed for 100 years, and maybe we have discontinued about 10 practitioners. And we are saying that we should be careful not to be excessively punitive. I don't know how that concept came. Have we been excessively punitive in the past?
I don't think we have been excessively punitive, and we should continue to not be excessively punitive. And I'll answer that question by the example that is happening in the UK today, where the British Medical Association is criticizing the General Medical Council for not doing their work, threatening to start their own regulator and threatening to have their own registry of medical practitioners. So while we have our inquiries and give verdicts with the public's interest in heart, you have to also remember that our practitioners are not practicing medicine in ideal circumstances, and that is why it is important that there are medical professionals in these inquiry committees, because they are the ones who know the background, how we work, what kind of situations they are in, especially in our smaller hospitals. Once the Ministry of Health can get its act together and make all hospitals superbly, equipped and so on, then we may be a little better place to be punitive. And I don't know when you were there, but I am in the PPC, and at least Epitakadu is the president, the chairman of that. And in the recent times, at least 7 out of 10 complaints have been forwarded to the PCC as having been found as prima facie evidence of, negligence or malpractice. Yeah. So maybe we are a little bit more punitive than when you were, so I don't know.
Yeah. Shall we? Yeah. Because of the time constraints, yeah, let's wind up. We'll take all the points that you all raised, definitely. Certainly, the points raised by Honorable Justice Yasanta Kordagoda and all the other points raised when we look at this, when we revisit the new Medical Act. Thank you very much for participating in this session. I think so. We'll conclude this discussion. Thank you.
Thank you very much, sir. And I would like to cordially invite Professor Vajra H.W. Disanaika, President of the SLMC, to present a token of appreciation to Dr. Sunil Vijay-Singha. Thank you very much, sir. Well, ladies and gentlemen, as we approach the conclusion of this remarkable centenary academic sessions, it is now my privilege to invite Professor Ranil Fernando, Chairperson of the Centenary Celebrations Committee, to deliver a summary of the proceedings. Sir, the floor is yours.
Thank you. I know that you all are sick of listening to talks, but before I commence, I must make a disclosure. I feel like the last batsman who has to score about 15 runs in 3 balls. How am I supposed to summarize all these expert talks with such great detail and delivered by eminent people in 10 minutes? So when we discussed this in the Centenary Celebrations Committee, they said, you do it. Now, being the chairperson, I could not throw it upwards anymore. So I said, okay, I will try. So I will do my best to summarize the proceedings of today. And I must say that I have gleaned most of this from the abstracts presented, and any misinterpretations, misrepresentations are entirely mine, and I apologize to all the speakers who did the presentations. So let's start. The health system, this is our vision. Basically, vision is given, it is to provide the best possible healthcare for the people of Sri Lanka. And our mission is to ensure quality healthcare by maintaining best standards in medical education and practice. These are the 2 aims that the Sri Lanka Medical Council wishes to obtained. And so therefore, we chose this theme, which is patient safety, quality, health care for all, a century of dedication, denoting that the Medical Council has always been committed to providing the best possible health care for our patients. Medical regulation has changed significantly over the last 100 years, and this has been reiterated many times today. Professional self-regulation is the original format, prevalent in many countries, and so far also in Sri Lanka. Globally, the trend is to have a system that is inclusive, transparent, and publicly accountable. A health system will face challenges, and medical regulators must remain not only responsive, but proactive, principled, and collaborative. The existing regulations in Sri Lanka installed by the British, as it has been told many times, are almost 100 years old and has caused many barriers to effective regulation. The post-independence era, the SLMC adapted to the emerging needs by expanding its regulatory scope, ensuring comprehensive oversight of health workforce. Maintaining regulatory independence has been a difficult task. Managing the tensions between protecting public safety and respecting professional autonomy with the reality of governmental oversight has caused many difficulties. As many as 32 changes to the medical ordinance has been made. Competency-based assessments for registration of foreign graduates has been introduced, and many other changes have been undertaken by the SLMC. The revision of the ordinance became imperative. After much discussion and debate, a new medical act has been drafted, and it is awaiting, as it has been discussed, approval. The new act will enhance SLMC's authority, accountability, including stronger disciplinary processes and recognition of medical education standards. Regulation, to be honest, is not about control. It is about ensuring a fair, safe, and resilient healthcare system wherever doctors can do their best to all their patients. So it's getting the balance right. Primum non nocere, I think this was said several times. The first principle that governs our practice is first, do no harm. Though attributed to Hippocrates, I think it's not really by him. Protecting patients from harm is not optional. It is a moral imperative and a foundation for resilient, high-quality healthcare for all. A culture of zero harm demands leadership commitment, system-based learning from errors, and patient engagement, and a just culture within healthcare. WHO, World Health Organization, adopted a resolution in 2019, initiated the Global Patient Safety Act from 21 to 30 and to protect patients. And also, they devised a registry of all the medical graduates, ensuring that only properly qualified graduates will participate in medical practice. The SLMC, in keeping with this, has created an independent accreditation unit with twin functions of obtaining recognition by the WFME, which we have already got, and duly accrediting all established national medical schools and also recognizing foreign degree awarding institutions. As guardians of public trust, the SLMC must reflect on whether its current processes for investigating allegations of malpractice and conducting inquiries are effective, timely, impartial in the eyes of the public and the profession. The SLMC must undertake evidence-based reform because it has a quasi-judicial investigative function as espoused by Justice Kodaguda. These include establishment of independent investigative units, legally informed disciplinary panels, procedural safeguards for both complaints and professionals, digital case management, diversification of sanctions to foster accountability, rehabilitation, and so on, most of which the SLMC has already undertaken. In ensuring the quality and safety in healthcare delivery, complying and maintaining global standards is the only way forward. Both in healthcare, in medical education, we must maintain global standards. The technological advances in the last few decades have posed challenges to ethical principles and the values that existed for hundreds of years. To navigate these ethical challenges, new concepts such as autonomy, justice, patients' rights were added to the much older principles of beneficence and non-maleficence and confidentiality. Formation of ethics committees at national and institutional level became mandatory. Navigating ethical complexities in modern medicine requires constant vigilance, identifying unethical practices, revision of existing guidelines, and development of guidelines, new guidelines whenever necessary. The environments in which doctors work to take care of their patients as regulators, we must ensure that the authorities provide the best possible facilities for the doctors, and that will ensure that the patients will receive quality health care. And this is one area where SLMC can make a difference, because we have to force the ministry to provide the best possible, and also the private sector to provide the best possible environment for doctors to undertake their practice. High standards are mandatory. I don't think there is any doubt. The regulator needs to take action when they are not met. And I don't think the SLMC will fail in this. The aim is to convince the registrants that they can be fully confident that the regulator will always act fairly, swiftly, respectfully, to increase the trust of all stakeholders. Integration of technology in healthcare has revolutionized patient care. I don't think this will change. This will only increase. The rapid evolution of technology presents both opportunities and challenges, requiring regulatory frameworks that are flexible and forward-thinking. By establishing clear guidelines and standards, the regulators can create an environment that encourages technological advancement while instilling confidence among patients and healthcare professionals. The aim is to create a future where technology empowers patients and providers alike, transforming the healthcare landscape for the better. I don't think there's much doubt about that. The rapid evolution of technology, particularly in terms of artificial intelligence, simulation, telemedicine, data-driven healthcare, is reshaping medical education globally. But the need to integrate technology is guided by an approach that ensures innovations serve a clearly defined educational purposes. I think that was stressed. If we don't have a goal, the just using technology is not going to solve the problem. Newer methods of immersive simulation-based learning, virtual reality, and mental rehearsal techniques, etc., have made a difference. But they must be used in a scalable manner, and that's what Dr. Jujiba Samarasekar said by start small, but act now. Think big, start small, act now. E-learning modules, simulation-based assessments, and AI-assisted diagnostic tools are integrated into training pathways to promote competence, patient safety, and lifelong learning. Several challenges remain. Faculty resistance, and this is fairly true in this country, varying levels of digital literacy among educators, concerns about reliability and questions were raised, scalability of the new technologies, and balancing innovation with accreditation requirements are recurrent problems, and I'm sure the regulators, particularly the SMC, will address these issues. Robust faculty development programs, early stakeholder engagement, and strong institutional support, both from the academia and also, particularly in this country, the Ministry of Health, is essential. Sri Lanka's health system must undergo a transformation. Hence, the educational components of the health workforce have also to be addressed. The content and format of the current curricula need to be delineated more clearly, and I think several areas such as interprofessional education, practice of digital health approaches, etc., were emphasized during the talks. Curriculum renewal and interprofessional education, education of clinicians, etc., all these things need to be thought of. From its inception, there is no doubt that we had very bright students. Selection tests, and this is a question that was said, should we think about it? Yes, we have to probably think about it and maybe involve both cognitive and non-cognitive ability assessment in the selection process. Modern approach is to view selection tests as the first assessment. That's a new concept a medical student undertakes in medical curriculum. And selection tests should not only address all cognitive and non-cognitive competencies, but should assess an applicant's potential using non-technical tests. Digital healthcare, telemedicine, data privacy, etc. are very important topics to be discussed. Digital health is the strategic use of information technology and communication and analytics across the care quantum. A legal and ethical framework that protects patients' information fosters trust. Diagnostic wearables, cloud platforms can safely be integrated when privacy by design and interoperable standards and robust consent models are embedded from the outset. Clinicians, researchers, policymakers must co-create a secure, evidence-driven digital health ecosystem that expands access, preserves confidentiality, and transforms patient outcomes. Research serves as a vital tool for national development by generating evidence-based insights into information, policy, drive innovation, and strengthen existing services leading to improved healthcare. Despite its potential, health research in Sri Lanka encounters significant barriers. These include limited resources. Government allocations for research and development show a positive trend, but overall expenditure as a percentage of GDP remains as low compared to other countries. There is significant potential for development in clinical and implemental research, which are essential for translating scientific advances into scalable interventions. Health economics and health technology assessment serve as vital policy tools to enhance research efficiency. Vision for the future, I think this was the last talk. Adapting current global trends in medical education and practice and fulfilling needs and expectations of more demanding society have been constrained by the 100-year medical ordinance. Globally, legislation for regulation of the medical profession has become more accommodative of modern societal needs. Despite 32 amendments, our ordinance lags behind woefully. A new medical draft has already been formulated, and the important things are like appointment of non-medical people into the medical council. And we hope that this new medical act will be in force fairly soon, and it will empower the medical council in lots of ways. And SLMC must remain responsive, proactive, accountable, transparent, and globally relevant. I'm sure the SLMC is committed to all these things for the next 100 years. Thank you very much. I hope I did justice to all the talks.
Thank you very much, sir. Ladies and gentlemen, we now move on to a special highlight of our centenary celebrations, which is the award presentation for the logo and stamp design competition. Firstly, allow me to share the story behind this meaningful initiative. To mark the historic milestone, the Centenary Celebrations Committee invited students from medical, dental, and allied health faculties across Sri Lanka to design an emblem for the Sri Lanka Medical Council, one that reflects a century of legacy, tradition, and progress. After careful evaluation, one exceptional design was selected as the official emblem. And this design inspired the commemorative stamp and first day cover created by the Sri Lanka Philatelic Bureau under the expert guidance of Mr. Pulasti Edriveera, who is a renowned stamp designer in Sri Lanka. And now to award the winner, I cordially invite on stage Professor Vajira H.W. Disanaika, the President of SLMC, Dr. Chandika Epitakaduwa, Vice President of SLMC, Dr. H.D.B. Herath, Registrar SLMC, and Professor Ranil Fernando, Chairperson of the Centenary Celebrations Committee. And ladies and gentlemen, it is now my great pleasure to invite to the stage the creative mind behind this distinctive and meaningful design. Please join me in extending a warm round of applause to Ms. Udani Sisiprabha Paranagama, a medical undergraduate from the Faculty of Medicine, University of Kelaniya, and the winner of the logo and stamp design competition. Let us honor her with a warm round of applause for her remarkable creativity and her valuable contribution to this historic centenary celebrations. Thank you very much, and thank you to our distinguished dignitaries. You may please take your seats. And we now arrive at another significant moment of celebration. This evening, the formal release of a special newsletter issued by the Sri Lanka Medical Association dedicated to the centenary celebrations of the Sri Lanka Medical Council in honor of a century of excellence in medical governance and service. And to mark this meaningful occasion, it is with great pleasure and respect that I invite on stage Dr. Surantha Pereira, the President of the Sri Lanka Medical Association, to present the newsletter to Professor Vajira H.W. Disanaika, the President of the Sri Lanka Medical Council, and Professor Ranil Fernando, Chairperson of the Centenary Celebrations Committee. Thank you very much. And now, ladies and gentlemen, to formally bring this memorable event to a close, I now have the honor of inviting Dr. H.D.B. Herath, Registrar of the Sri Lanka Medical Council, to propose the vote of thanks.
Distinguished guests, speakers, participants, ladies and gentlemen, good afternoon. It's a great honor and privilege to deliver the vote of thanks at the conclusion of this memorable academic sessions held in celebration of the Sri Lanka Medical Council's centenary. First and foremost, I extend my heartfelt appreciation to all participants who showed great enthusiasm and interest in these academic sessions from the moment we opened the registration. Your presence, active engagement, and intellectual curiosity have given life and value to every session held over the course of this event. I sincerely thank the President, Vice President, and the members of the Sri Lanka Medical Council whose guidance and leadership shaped the vision behind this academic event. My deep gratitude goes to the Chairman, Professor Ranil Fernando, and the members of the Centenary Celebrations Committee, sir, who worked tirelessly over the many months to plan, coordinate, and deliver this event at such high standard. I wish to thank Dr. Janaka Pushpakumara and Dr. Tenuan Wickramasinghe for being the overall in charge of this, in conducting these sessions, which I believe a success. Thank you, Dr. Janaka and Tenuan. We are also indebted to all chairpersons, moderators who presided over the plenaries, and to the resource persons, both local and international, who so generously shared their expertise and enriched our collective understanding across the range of important subjects. A special note of thanks must be extended to our three distinguished overseas guest speakers, Professor Dame Carey McEwen, Chair of the General Medical Council of the United Kingdom, Mrs. John Simeon, Chair of the International Association of Medical Regulatory Authorities, and Professor Dujipa Samarasekara from the National University of Singapore, for sharing their deep expertise and valuable perspectives. We are also grateful to the Secretary to the Ministry of Health and the representatives of the UN agencies in Sri Lanka who spared their valuable time to be with us today. Our thanks goes as well to the special invitees from the WHO-sponsored workshop held in 3rd and 4th of July 2025 in Colombo, whose presence added international relevance and strength to these academic sessions. I extend special appreciation to the President, Secretary, and the editors of the Sri Lanka Medical Association for their significant contribution to the Centenary by dedicating a special issue of their newsletter to this historic event. Thank you, Dr. Suranthi. And we are truly thankful to the management and the staff of the BMICH Mountaineer Hotel for their excellent facilities and services which ensured the smooth flow of our sessions. I would also like to recognize the efforts of several individuals whose contributions added a unique charm to this event. Dr. Anojana Jayaseelan for her outstanding comparing, Dr. Chamika Senanayaka for his valuable IT support, Ms. Udani Parnagama for designing the official Centenary logo now proudly displayed across all these materials. Our thanks also goes to AV Productions, our event manager, for their seamless coordination and unwavering support. We gratefully acknowledge the contributions of all media institutions for providing wide and meaningful coverage to the event, and the Inspector General of Police and Sri Lanka Police for their support for the security arrangement. I should not forget the contribution made by the group of medical and dental students who supported us as volunteers to make this event a success. Last, but by no means least, I extend my deepest gratitude to staff of the Sri Lanka Medical Council, whose commitment, hard work, and dedication over the past many months have been the backbone of this event's success. Finally, I wish to thank all the contributors, suppliers, supporters, including those whose names I may have not mentioned specifically, for playing their part in making these celebrations truly memorable. Thank you, one and all, for joining us in this milestone in the history of Sri Lanka Medical Council. Thank you. Thank you very much.
Ladies and gentlemen, as we draw these landmark centenary academic sessions to a close, we extend our deepest gratitude for your gracious presence and meaningful engagement throughout the day. It has been a truly inspiring occasion befitting this historic milestone. And we look forward with great anticipation in welcoming you once again this evening for the commemoration ceremony, where we shall continue to celebrate this remarkable centenary together. Thank you once again for your presence, ladies and gentlemen. May I now respectfully invite you all to please rise for the national anthem.
Apa hada kula